Good morning, everyone. Just a quick announcement. If you are looking for the Marketing for Access Communications Mini Summit, it is in Conservative Tory, BC, which is right next door. Thank you.
you're coming back from the Olympics. Normally, you come back from the Olympics.
Good morning, everyone. Good morning, good morning. How are you this morning? Good morning, everyone. All the way in the back of the room. I see you over there. Good morning. My name is Dr. Roger Mitchell, Jr. I am the 126th president of the National Medical Association. So good morning to you all. I think you heard from my colleague yesterday. Dr. Brandy Freeman was here, president-elect for the National Medical Association. NMA and Nmqf are great friends and colleagues. I have our past president, Yolanda Lawson, in the building. Please give her a round of applause. And for a long time, we know that black physicians have led the way as it relates to equity, as it relates to access. And so this year's theme about access is extremely important. Understanding how our patients, our physicians, our communities need to make sure that we have access to equity and care in this country. Today, we know it's even more important today than ever before that we come together intergenerationally, as men, as women, no matter what our gender, age, race, or creed, coming together in a way that ensures that people are healthier, that people are better. We know that just as of late, there was a rash of domestic violence in our community. I'm a forensic pathologist and often say that I see failed policy on my autopsy table. It's these rooms that allow for us to come together, learn from one another, and make sure that we decrease mortality and morbidity in all the communities that are in need. So I wanted to just come by and say good morning. I'll be around most of the day, hopefully connecting with you all, hearing about how our community, 126 affiliates across six regions, how we can come out of every state, work together with you to make sure that there's access. I'm a preacher. If you can't hear a little bit of the cadence, I'm trying to hold it down a bit. I'm a preacher, so they said, come up, say hello, say good morning, but then pray for the food. And so when you're a good preacher, you get multiple opportunities to give a word. So if you don't mind, if you could just bow your heads for a moment. We come to you, no matter what we call your name, we know you are the Most High. The tradition that I come from, we call you Jesus the Christ, but we know that you come in many forms to many people under many circumstances, to heal the sick, to relieve the poor. You allow for us to serve the disenfranchised. So we thank you. Thank you for allowing us to be your hands and your feet, doing the work here on earth, fighting the battles against the evil one, both seen and unseen. So give these men and women courage, give them capabilities, bless them from the top of their head to the soles of their feet. Give them everything that they need in their finances, in their relationships. Let them today just feel a burden just be lifted off their shoulders in this moment. Let them know that the work that they're doing is being seen by you. Let this food nourish and strengthen us. In your name we pray. Amen. Have a wonderful, wonderful day, everyone.
Good morning. Dr. Mitchell, thank you so much for those remarks. Appreciate it. Value greatly our relationship with the National Medical Association. It's impossible to stand up here and try to give you a summary of yesterday's meeting for those who were here with us. I was particularly struck by the fireside chat with 3 members of Congress, and then last night at dinner, the 3 members of the DMV Health Department. And in a way, everybody was saying the same thing. We are in an extraordinary moment when resources are being pulled away from healthcare, and everybody's trying to make do, and everybody is being encouraged to be silent in that moment. It is hard for Nmqf, and I know the folks here in the room with us, to be silent in that moment, and we shouldn't be. One of the great values of democracy is that we all have a voice, and we should use that voice, whatever the moment is. I have to tell you, I'm incredibly optimistic. I see the science, and it's irrepressible. Where we're about to go. So those of you who don't know me, I tell you my doctorate was in history, but I was really studying classical medicine. I was studying Aristotle and Hippocrates and Galen and blood leeches and God knows what all, and understood that world and that language, and what they were struggling with. This is before anybody knew about germ theory or even how our bodies work. Back then they thought our stomach was like a furnace. You ate food and it cooked the food in your stomach, and I don't know what else they thought was going on. But in any case, understanding that past, you understand our future. We are doing things that they could not even begin to imagine. We're going places that even in their wildest dreams, they couldn't even think of. And I'm telling you, by the time we get to 2050, we will do just incredible, amazing things. The companies that join us, and you want to recognize them later on, but I see their science. I hear from their scientists about what they're doing and what they're capable of doing and how they are transforming healthcare. Irrepressible. I don't care what anybody thinks. But I knew future generations are going to have longevity, that people historically, even in the 20th century, couldn't see, couldn't imagine, couldn't think of. Our fundamental problem really gets down to how do we pay for it? How do we provide access to everybody? How do we bring everybody along? How do we leave no one out? That's the struggle. It ain't the science. The science is not the struggle. The struggle is that we have to reorder the way in which we build our logistical systems to provide health care in every American community. The very fact that we stand up and use the word underserved is all you need to know about what is going on. The very fact that our medical administrators use that word is all you need to know. That's not our future. That's not where we're going. That's not the place. And so I was listening intently yesterday to members of Congress, 20th century. They ain't on Star Trek. I'm sorry, but they're not. I listened to the administrators who have to take the proportions that are being doled out and try to feed a multitude and can't do it. They can't do it. So the work is at hand now. How do we reorganize? Fearlessly, without fear, to carve a future. And, I'll talk about it later on today, but I'm going to end here with this. We don't ask each other to do great things together. Our leaders don't stand up and say, we need to do great things together. They want to divide us, set us at each other's throats. But they never, ever come to you and say, I need you to work with me to do great things. When you find a leader who says that to you, a servant leader who says that to you, then you know you've got the person, right? You'll know. I've had, along the way here, I've been doing this 25 years, and I've had the opportunity to work with really remarkable people. People that you can trust, that you don't have to worry about. And our next speaker, Laverne Burton at the American Kidney Fund. For those of you who don't know, African Americans, Hispanics disproportionately suffer from kidney disease. Almost 50% of everyone on dialysis in the United States is either African American or Hispanic. Laverne and her group tends to that community. And I've enjoyed listening to her, the work that she's doing, and she is in an unusual place in our society for an African-American female. I'm just gonna go there and say that, right? She's doing unusual things. So it has been a great honor and pleasure that I bring Laverne Burton. Thank you.
You're coming back from the Olympics. Normally, you come back from the Olympics and you have a parade or you go to the White House or something like that. You did those things to celebrate, and then you were headed to the doctor. And somewhere in that journey, the doctor said, you know, here's this very young man, I just won a gold medal at the Olympics. And the doctor says, you're approaching kidney failure, or you, and how did that feel at that moment that you were
You know
told
what?
that?
At the time, you know, I'm gonna tell you when I got the news, LeVar, my head fell in my hands, and I asked God, not why me, but why right now? You know, I had these intentions to go into the season, to start the year off, get ready for this, you know, a championship run. I was like coming off this amazing year where I was first team all NBA and, you know, defensive player of the year, you know, all of these accolades, and then bam, life just happens. You know, I felt like I was a picture of health, and I was at the top of my career. Scared for myself, for my family. I was overwhelmed. Uh, but now I realized I was given this amazing opportunity to make a difference in other people's lives. And that's what it was all about. Me going through the pain and the discomfort just for me to make a difference in somebody else's life.
Absolutely, and what a difference you've made.
Good morning, everyone. I have the great privilege of working with people like Alonzo, my team over here, and patients around the country, and people and families around the country who are dealing with the challenges that are presented by kidney health. Today is a very special day in our world, and I so much appreciate the opportunity to partner with Gary and the team at the National Minority Quality Forum to observe this day. It's called AMKD Awareness Day. AMKD stands for APOL1 mediated kidney disease. And Alonzo has that disease. He also has FSGS. And for the last couple of decades, he has been on his journey to keep himself healthy. He has been very, very fortunate, which he recognizes and he shares in this video, which we are releasing today, April 28th, because it is the last Tuesday of April. And since 2024, we have observed this day and will continue to observe this day. And you say, why? Why do we do this? Particularly, why do we do this at this conference? AMKD is a form of kidney disease that, yes, overall kidney disease disproportionately impacts Blacks, but AMKD in particular affects people of ancestry from Western and Central Africa. And that is why we take the time here and are so grateful for the opportunity just to talk about it. Please go to our YouTube channel, go to YouTube or go to the American Kidney Fund website, and you can watch this podcast in its fullness. Not only does Alonzo talk about his journey with his kidney health, but he talks about the importance of giving back to his community and all of the work that he is doing in South Florida and indeed has done around the country. And we're so grateful for the partnership that we have enjoyed with him. Now, many of you saw him last year when he came to the National Minority Quality Forum and had the opportunity to talk about part of his story, but you'll hear the whole thing. Now, some of you may know about AMKD, and some of you may not. Let me tell you a little bit of background about it. All of us have two APOL1 genes, one from our mother, one from our father. Over many years, people in Western and Central Africa, over hundreds actually of years, the genes changed, and there were variants of the genes, had the positive effect of protecting people against African sleeping disease, But we didn't know for, decades later that it had the adverse effect of increasing the risk of kidney disease. So people who have two APOL1 genes with variants are at a much higher risk of getting kidney disease. About 13% of blacks in this country have the two gene variants. About a fifth of those people, 20% of those people, will get kidney disease. And what is particularly alarming about this form of kidney disease is, number one, it begins at a much earlier age than most other kidney diseases. You might recall, I'm not sure how many people in the room are old enough to recall this, but I certainly do, that it was in the late 1990s that Alonzo's journey first started. And there's so many other people who are struck with this kidney disease as early as the age of 15. The average age for getting it is somewhere between 15 and 39. It progresses to kidney failure much more quickly than other forms of kidney disease, 10 to 12 years earlier. And so it is so important that we in our community get the word out, take the word back to your communities, to your families, to talk about family history, to talk about, well, there's somebody there that I didn't know too well, who was a cousin, who was on dialysis, and you start thinking about the numbers, and you say, I've got quite a few people in my family. Look into that. Talk about that. Share this information with others. And there's a lot more information on our website about this disease. That is why the American Kidney Fund has really focused on AMKD awareness, to make sure that people know about it, that they can have the conversations with their family, that they can have the conversations and partner with their healthcare providers so that they get into treatment early to try to slow down the progression and hopefully not end up in kidney failure. We are very encouraged by the fact that this particular disease was actually discovered through some NIH research, which is why research is so important, as Gary was saying. Just in the last decade or so. And so it is something that is very new to us all and very urgent that we spread the word. We're grateful to have also partnered with Vertex Pharmaceuticals in supporting our AMKD awareness activities. And we will continue this. We want to make sure that everyone knows about it, that you have the opportunity to do something about it as early as possible, and to achieve your very best, our very best healthcare outcomes, particularly kidney care outcomes. So thank you again, Gary, for the opportunity to share this information. I know that everyone will continue to enjoy the conference.
both. I'm going to direct some to you panelists, and then there's some I'll ask for everybody to weigh in. But I know we didn't, well, I guess I didn't get to do the prep call. But feel free to weigh in. You know, if Sherelle says something, Leo jump in, or Yolanda. Just, we can make it conversation.
Because you're professional, this is how you know, like, when you're president, you know, in there, you kind of know these things, you know. Is Gil still here?
We are change makers.
A new biotech company is promising to revolutionize the way we treat disease with medicines from living cells.
The original risk takers.
Genentech promises to leave no patient behind.
With a foundation of forging life-altering scientific breakthroughs. But our quest has evolved. It's bigger.
An unprecedented convergence of medical knowledge, technology, and data science is revolutionizing patient care.
And bolder.
An ambitious vision to boost medical advances at 50% less cost to society.
Our focus is even greater than medicine.
Genentech is working to eliminate racial bias in clinical trials and STEM education.
It's to solve the world's most complex healthcare challenges and to improve the lives of all patients.
Good morning. How's everyone doing? Good morning. Well, welcome. This is the first session of the second day. When hospitals close and systems consolidate, what it means for affordability and access. And this is going to be a wonderful conversation. I am Linda Goldblount, President and CEO of Community Catalyst, an organization that invests in state and community organizations to make sure people have access to quality, affordable care in a system that's accountable to communities. So we're going to have a broad conversation today about kind of what that means and what the issues are. And I've got this amazing panel. But before I introduce them, and we are waiting for one more panelist who's on her way, I just sort of want to set the stage. We're meeting at a moment that will define, I think, the next decade in healthcare. I think Dr. Puckrin talked about that. In the last 4 years, more than 150 rural hospitals have closed or converted to limited services facilities. Maternity units are disappearing at the rate of nearly 1 per week. And today, the top 5 health systems in this country control more than a quarter of all hospital beds. Consolidation and closures don't just change where care is delivered, they change who can get it and at what cost. Consolidation is not a future risk, it's a present condition. And at the same time, federal policy is moving in a direction that compounds these pressures. I think we're all seeing that. Many of them, proposed Medicaid cuts risk eliminating coverage for millions of people, many of them in communities that have already lost a hospital. The unwinding of ACA protections, reductions in CMS reimbursement flexibility, and rollbacks of price transparency rules are not abstract policy debates. They are financial and health trade-off decisions that will determine whether a woman in rural Alabama delivers her baby safely or must drive 90 miles hoping she makes it in time. I'm from Georgia. We see this all the time. The people in this room, all of us, have the relationships, the resources, and the reach to influence what happens next. Pharma, health systems, policymakers, and public health leaders sitting together is not a coincidence. As Gary said, it takes us being together. This is an opportunity. The question this session will present to all of us is, when care becomes concentrated in fewer hands and in fewer places, who's accountable for what remains? Who gets to decide when a service is too expensive to keep, and who pays the price when it's gone? Access and affordability are not separate conversations. Care that exists but can't be reached is not access. Care that can be reached but is not affordable is not care. And care that does not consider the needs of the community is not accountable. Our panelists today will help us name what's broken, what's working, and what the opportunities are going forward. So let's get into it. I'd love to make some introductions. Today, we have an amazing panel. Sherelle Bird, who's a co-founder and executive director of Sowega Rising, and is a leader of a broader group of rural health advocates. She spends her time highlighting how hospital consolidations and closures are reshaping access to care, especially in Southwest Georgia and other rural areas. Dr. Leonard Seoane, Leo, serves as Executive Vice President and Chief Academic Officer for Ochsner Health, and is the founding dean of the Xavier Ochsner College of Medicine, the 5th HBCU medical school in the US. That deserves an applause. And he's a board member of the National Hispanic Medical Association. And Dr. Yolanda Lawson, whom I've had the pleasure of working with for several months, is a board-certified OBGYN and immediate past president of the National Medical Association. And in addition to seeing patients, she's deeply committed to improving maternal health outcomes, eliminating health inequities, and addressing the physician workforce diversity issue. And I will introduce Dr. Cameron Blakemore, and so when she comes up on stage, you'll know who that is. She started her policy career through the Congressional Black Caucus Foundation's National Racial Equity Initiative Fellowship, and she now brings that lens to the office of Congresswoman Terry Sewell in Alabama, where she serves as policy advisor. So welcome, and why don't we start by sort of grounding this conversation in real experience. Sherelle, how do hospital closures, especially in rural areas, reshape access, cost, and continuity of care, especially in places that have been turned into what we call medical deserts? And what happens at the personal level?
Good morning. So thank you for the question. It's a pleasure to be here with you all today. So I'm Sherelle Bird, and she says I'm an advocate for rural communities. And before we get started, I do want to start off by saying that no one is banished to rural communities. We actually choose to live there. Thank you. I got one clap. I'm a country girl at heart. I'm a daughter of the Black Belt, and I've lived in Atlanta for about 10 years, and I do know very well that Atlanta is very full. It's very population dense, and so many people do choose rural communities as a place to live because it is a slower life and a slower pace, which was the case for me moving back home to my hometown of Albany, Georgia. But when I got there, I did discover that healthcare is not the same as it is in urban centers. I'm in Southwest Georgia, and we have a lot of issues when it comes to health. Welcome. We have a lot of issues when it comes to health, and one of the major issues, as Linda mentioned, is we are in a medical desert. And I want to illustrate a little bit what that looks like by starting off with this statement, and this is actually a quote from Bono that says, "Where you live should not determine whether you live." Healthcare should not be location or geographic specific, but unfortunately in rural communities that is such the case. So imagine with me if you're living in a community and your hospital is probably the only hospital that takes care of about 4 to 5 communities around you, and you are in the midst of COVID-19, it's March 2020, and you discover that your hospital has closed because there's a sign on the door when you walk up to the door. that is not how a community should learn that their hospital has closed. And I want to illustrate the impact that that has on rural communities. So this hospital is probably the largest employer of jobs in that community. Hundreds of jobs are now lost from that community, which means people are moving or population decline. People will leave the area for new jobs. Their homes will be put up for sale, which means property taxes will decrease in that community, which means municipalities will start to struggle. But also on the healthcare side, it's a black hole basically for that community. So the entire medical infrastructure disappears. Your vision care, your dentists, your chiropractors, your OBGYNs all leave the area. Additionally, your EMT and medical transport also leaves the area. And so your nearest hospital system, as you alluded to, is probably about 90 minutes or more away, which means you have to, in many cases, cross state lines, sometimes just to get to the next hospital system. So if you're in need of specialized care, if you're in need of emergency care, this is a really dire situation. I want to call the name of a 16-year-old in our community. His name was Tyree Campbell, who, as a result of an accidental shooting, found himself in a situation in Cuthbert, Georgia. And this community that I mentioned, that I'm illustrating, was actually Cuthbert, Georgia, where their hospital closed at the height of the COVID-19 pandemic and left a lot of the people in that community really, really devastated, not knowing where they would get care. But there was a 16-year-old in that community, Tyree Campbell, accidental gun shooting, would have been what should have been a preventable injury, or injury that, while it is serious, did not have to be life-threatening. But because the only EMT in that community in Cuthbert, Georgia, was already on another run, it took 45 minutes for the EMT to show up, resulting, unfortunately, in his untimely death at 16 years old. So again, I say, where you live should not determine whether you live, but that was the case for Tyree Campbell. And for many others, mothers, when we talk about the Georgia's maternal health crisis, which, if you don't know, Georgia is one of the most dangerous states in the country for a black woman to give birth. It's even worse in rural areas. And what this looks like is, again, women living in rural communities that don't have access to medical transport. Their nearest hospital is an hour away. And there's a statistic that says for every 15 minutes, a woman goes without medical care, a pregnant woman or a woman in labor, she's causing more risk to her body and to that of her infant child. So this is the reality and the impact, and I'll end by saying this, the physiological toll this takes for people living in rural areas, the fear. We actually partner with community, because of our funding from Community College, we were able to go to Cuthbert and speak to people in that community about how they felt after the hospital closure. And they spoke about the overwhelming fear of not having access to a local hospital, and that fear of not having safety, not having access. It starts to erode at your mental health. Your cortisol levels go up when you do find yourself in a situation where you can't be there to take care of your aging parent who's in a town 2 towns away. You have to leave work to take care of them, or you have to go in an emergency to a town 2 towns away. The economic harm that causes to you as well. So it is, like I said, a black hole in many communities in rural Georgia. When in urban centers, if a hospital closes, you can go about 15 to 20 minutes away. For us, it is devastating when a hospital closes.
Yeah, thank you. In studying public health, and we look at how people use healthcare. You all have seen this many times. A woman goes without regular prenatal care, and the first thing we do is blame her. But if your prenatal care is a 90-minute drive away, and you've got a job, or maybe 2 jobs, you've got a couple of kids, it's hard. It's not that she doesn't want to get prenatal care, take care of herself, but how do you fit in what is basically a half a day? Then you've got to take off of work, and depending on your job, you may not get paid. And this is every month. And then toward the end, it might be every 2 weeks. And this is for an uncomplicated pregnancy, Yolanda. I know you know this. Sherelle, you talked about, when a hospital closes, people lose jobs, but there's a broader economic impact. Can you just talk a little bit about what you see in rural Georgia, and I think about the safety net also. When the hospitals close, where do people go?
That's a great question. And again, it creates, like you mentioned, a desert, several deserts, right? We have maternal care deserts. We have dental care deserts. We actually have an issue. We started an oral care program in our community because we found out that children ages 0 to pre-K, their teeth were already rotting. Because they didn't have access to early oral care because there's only one dentist in a community, maybe that takes care of 3 communities. And in our rural areas, many of our dentists don't accept Medicaid. So if you're lower income, you don't have anywhere to go. So it causes a significant strain on the economy in the community, but again, it also, as I illustrated earlier, it means that you're losing jobs, you're losing tax revenue, you're losing a lot of industries in the area as well that look at hospitals in the area as a part of the social determinants of health and how they make a decision of whether they will even locate a corporation or industry in a rural area. And so we've seen significant loss of jobs in terms of industries just leaving the area as well because of our healthcare system. The other thing is we're seeing corporations that are having to send people to other hospital networks outside of our area, which causes a huge burden on them economically, but for them to get better quality care or specialized care, we don't have the specialized care like cardiac care, mental health care, pediatric care that you see in other communities. And so people are having to transport, and even our hospitals are having to airlift people all day. Like our office is right outside of our local hospital, and we hear our helicopter every 10 minutes because they don't have the specialized care, and so now they're having to life flight people to other hospitals across the state. So it causes a huge significant drain on the hospitals as well to be able to overcome that. And then I'll say the last thing is because we live in rural areas that tend to be more impoverished, and people rely on Medicaid, we're even seeing things like the impact of HR 1 on hospital systems, especially in rural areas. And so many of the hospitals are projected in our rural area even more to close in rural areas because of the impact of this HR 1 bill. And so our organization has been talking to hospital leaders as well as community leaders to find out what are you doing to prepare for this? What is the long-term plan to support and sustain your hospital once this hits in January 1st, 2027? It will be significantly devastating if we don't come up with a recovery plan.
Yeah. So along those lines, Leo, as there's hospital consolidation, I said, and as I mentioned earlier, there is serious consolidation happening. As you think about a large health system, what is the role of a large health system to improve access to care in rural areas? And I say, do you think there is one? And if there is, how can this happen? What can large hospitals do?
Yeah, so I'll give you a case study of Louisiana, and I'll compare it to Mississippi, and then we'll talk about what happened in Louisiana and how large health systems in Louisiana were able to impact and continue care in rural, and really it should improve care. So go back to 2016, Louisiana expanded Medicaid, Mississippi did not. In this past 10 years, there's not been one rural hospital that's closed in the state of Louisiana. There's been 5 hospitals that have closed in the state of Mississippi. There's still incredible pressure in the state of Mississippi. I don't know if anyone's from Mississippi, but Ochsner Health is the largest health system in Louisiana. We span across Mississippi. We have 46 hospitals across Mississippi, and actually one in Alabama, one small hospital in Alabama, rural hospital in Alabama. But if you look at that case study, you say, well, what was the success of Louisiana? It was Medicaid expansion, Medicaid expansion, Medicaid expansion. But the other part was we had a visionary governor at the time, Governor Edwards, who said, I'm not going to let a rural hospital close for all the reasons you have nicely laid out. And so he would approach, and he approached Ochsner on more than one occasion and said, I need your help. We have this hospital, it's under financial pressures, can you come in there and help? And the combination of a public-private partnerships that we formed throughout Louisiana and the Medicaid expansion allowed us to keep those hospitals open. So I think that's what large health systems can do and get into public-private. Of course, we have resources of large health systems that can really, all the back office, all of the economies of scale that you could bring to help. But the other important thing is quality of care. And we talked about we don't have enough specialists in rural areas, and people ask me, why are we starting another medical school? We don't have enough doctors in the United States of America. And that is, I think, a crisis that gets overlooked many times. When the AAMC says we're approaching 86,000 physicians short, and now the new report says by 2050 we could be up to, worst case scenario, 300,000 physicians short, best case scenario, 129,000 physicians short. That is not evenly felt throughout the United States. It is the rural areas and some of the urban areas that feel that impact significantly more. In states like Louisiana and Mississippi, we feel that impact significantly more. We need more doctors. That's what the Xavier Oxford College of Medicine will address. But we also need doctors who are willing to go and serve in those communities. But what a large health system, an academic spoken hub model can do is coordinate that care. And we can do that via telehealth. We can do that via virtual consults, where the primary care in the rural can get a virtual specialist consult right there at that moment. So we have these e-consults, electronic consults. We can do that also by having a transfer center that coordinates that care, so no patient that's in one of the smaller hospitals ever gets told no. We have a one call, that's all kind of philosophy, so that rural hospital can get that patient placed. And we will place that patient, even if it isn't in our health system, we'll place that patient somewhere in the Louisiana area, because we know it's about the patient's life. And so those are the things they can do. And then I think the other thing, we need innovations, because we're not going to solve the 300,000 physicians short in the next few years. And so we do need innovative approaches, and I'll just give you a couple examples of a couple of innovative approaches. Digital hypertension, digital diabetes programs. So we published a study looking at Medicaid patients in rural areas in North Louisiana enrolled in a digital hypertension or diabetes program. So these are programs where the patient gets a blood pressure cuff, they will take it at home, it uploads to a PharmD who manages that patient's blood pressure. The patient is an app constantly getting, hey, did you take your blood pressure today? You're doing well, comes with a health coach. And we demonstrated that those digital hypertension diabetes programs decreased ER visits, decreased hospitalizations, had actually better blood pressure control than usual care, which is you'll go see your primary care doc 4 times a year and have to make decisions based on 4 blood pressures. Those are the types of, I call them physician expander kind of programs, where you can provide care in communities while we try to increase the number of doctors in this country.
So are you saying technology is going to be the solution?
I think technology has to be part of the solution.
Okay. So, Yolanda, you spend a lot of time talking about the workforce issue and particularly diversity. So how, as you think about healthcare consolidation, and you live in a special state as well.
Real special.
Real special. Both, horizontal and vertical. How does this consolidation shape what patients pay, but also how providers are reimbursed and what kinds of services can actually be offered to them? We'll talk about decision making in a bit, but sort of what is going through the minds of providers as you face the kinds of issues that Leo's talking about?
Yes. Good morning, everyone. So I just want to level set first, because I don't take that we all come from the same place. So I'm Norwegian, I'm based in Texas, so that's my special state. The second piece, I think, is important to root and ground us all, the difference between horizontal and vertical consolidation. So when we think about the healthcare ecosystem, when we talk about this horizontal, consolidation, we're talking about really these mergers and acquisitions, right? We all have seen hospitals buying other hospitals, right? Like buying like. And then you think about the vertical consolidation, certainly when you think about the clinicians, right? The physician workforce. You think about those are maybe insurance companies, hospitals buying independent physician practices. That's what we need on that vertical piece. And certainly as a physician, it's impacted what our workforce is, how we operate, what we do, and it certainly impacts cost. There's much data out there around the cost, right? When physician practices are acquired or we're employed by a system, the cost of care just goes up, right? And then if you think about those who are uninsured, they're probably the most exposed, right, to these cost pressures. And so we've seen some legislation around cost and price transparencies, all of this, but it's not enforced. And then the second thing, I'm an OBGYN, and so I think it was in 2023, I remember getting a call from a few colleagues. They got up to go to work that morning. This is an OBGYN, right? We in the office, but we also are in the hospital. We need an operating room. We also need labor and delivery. We need a place for delivery. My colleagues went to work to the hospital, and chains were on the door of the hospital entrance. The hospital had closed. So what also you may not or may not know, for those who are not clinicians, the hospital doesn't have to tell us, right? If you're an independent practice, you don't work for the hospital, does not have to tell you or me, who I have privileges there, that we're closing. Colleagues went to go to work, chains are on the door, and certainly I'm sensitive to this because of maternal health care, right? I'm an OBGYN, like I said, you heard me say I need labor and delivery. And the other thing you have to realize, we can't just, patients do this all the time, they come in and just think, I can go over to here or here and deliver you, and we can go where we want. No, a doctor has to have privileges. And to get privileges, takes several months. And so colleagues were calling because they needed coverage. Where are these patients going to go? Patients were just walking into our emergency department for care. So you lost continuity. You lost the economic impact, not only of those hospital employees, but the doctor's offices who go to that hospital. All of that impacted. So then you have people closing practices or whatever because they can't sustain. And so from a workforce piece, it has a trickle-down impact. And I remember because at the time, this was in 2023, Congresswoman Kelly, I don't know if she's here, but I saw some of her team here, she introduced the Carers for Moms Act. And in one of the provisions in that bill was that there's a 90-day disclosure, because I participated in her press call talking about this, how, and this wasn't the only, I gave y'all the example, doctors literally going to a hospital to work and the place is closed and didn't know that it was coming, so you also don't have the time, right, to make those types of adjustments. So I'm highly sensitive to this, probably because I am an OBGYN, and the specialty is uniquely vulnerable. I grew up in a rural community. I grew up in rural Arkansas, right? My town is about 10,000 people. We still have a hospital, but my mother lives there with multiple chronic conditions, right? And so I'm thinking about this not only from my professional framework, but also from a personal.
So as we think about consolidation, I mean, I can't imagine this experience of going to work and there's chains on the door.
And I live in Dallas. So the other thing I ask everybody to think about, we've talked about rural, but this has happened urban and suburban. So this is across the spectrum, and we must be thinking about that.
So as a physician or nurse, just a healthcare provider, you show up, the chains on the door, what's the psychic impact? I mean, are your colleagues saying, you know what, I'm out, I'll just do something else?
Yes.
Because Leo talked about the shortage, but we have a shortage in training people, but are people just getting frustrated? Right,
so he's talking about the shortage, but we'll never get to the state we need to be because I know everybody hears about burnout and all of these things. Things like this contribute to that, to physician satisfaction, to our vulnerability, right? Here you are trying to have an independent practice, but you have dependencies. And so, yes, all of this contributes, I remember several of those early retirements, decide to do something else. I don't want to do this anymore. If you can think about the impact, not only on the community, not only on the patient, but also there's a significant impact on the physician or the other clinical workforce.
Yeah. So this leads to sort of decision making, because these decisions are happening. I can tell you, for the most part, community has no idea what kinds of decisions are being discussed, what kinds of conversations are being had. I live in Decatur, next to Atlanta, and Atlanta Medical was a private hospital serving a low-income community, and the hospital system, Wellstar, bought it. Next day, closed. Nobody in the community knew. A good friend of mine is an OBGYN there and said 80% of our patients walk. And so at the press conference, a reporter said, so what's going to happen to these patients? And this healthcare executive said, well, they can go to Kennestone Hospital. If you know anything about Atlanta and public transportation, you can't go to Kennestone Hospital if you can't
By
drive.
MARTA, no.
You know, MARTA's not taking you there. So, for the community, it felt callous. So, the question was, well, who was making these decisions? Who was in the room? We likely are not going to have success taking on private equity. I mean, BlackRock has $11 trillion in assets under management. Well, if they want to buy something, we probably can't stop them. But I'm wondering if communities, I talk about this all the time, can communities negotiate? I mean, could they have negotiated had they known and said, okay, you're going to buy this hospital, you're going to close it. Can we keep the prenatal clinic? Because we need that. Can we do something? So, Cameron, because we know you have the answer. Policy falls short of protecting us. And we talk about affordability in healthcare. Everything that's been discussed just drives prices up. So as you think about requirements and accountability measures and policy tools, what could be in place to actually help communities maybe negotiate, but just to make sure that there's some transparency on these decisions so that people, what are you saying, have 90 days? Like, just have some time to plan for when a hospital is going to close or limit services.
Yeah, absolutely. I think, hi, good morning. I'm Dr. Cameron Blackmore. Sorry I was late to the discussion, but I think oftentimes once we find out, and I've been in my role for 3 years, right before I came into my role in Congresswoman Sewell's office, and her district is largely underserved rural, and then we have underserved urban as well. And right before I came in her office during the COVID pandemic, that was when we experienced our last, well, not our last, but a big rural hospital closing in one of our counties. Since I've been in the role, we currently have another rural hospital that has closed that is currently negotiating. The mayor and the city council members in that area are negotiating to get the doors back open, but we just haven't gotten there yet. And our office, we try to be very, very responsive and involved in these negotiation processes, but we also need the hospital administrators and the policymakers at the local level to come to the table and give us as much information as possible so that we can know what's going on, so that we can see how we can weigh in. Because oftentimes we find out from a newspaper article, and that's how I found out a lot. Since I've been in this role since 2023, we've had 4 labor and delivery units closed within the state of Alabama, 3 of them in our district, 1 right outside of our district where some of our constituents do go to receive care. And most of those I found out from a newspaper article. So the communication has to be there between federal policymakers and the local communities. I would start with that. Is basic, but I think that in DC and on the Hill, we do need to think about how we can better serve our communities. And quite frankly, HR 1, cutting trillions of dollars to our healthcare system through Medicaid, was definitely not the answer. And so now we're at a time where you already have a strained healthcare system that is going to experience even more constraints due to that major decision. What I would like to see, if I could have 3 wishes in this space, I would like to see HRSA step in even more. So HRSA does provide technical assistance to rural hospital administrators. I think a lot of administrators, they either don't know that that help is available to them. They don't know kind of I can understand that when you're in your role and you're trying to keep the doors open, you're trying to get your hospital from being in the red back up to the black, you may not feel that this technical assistance program is going to help you. You know, you want some cash. I think that that's another way we could be helpful, instead of slashing our budget, providing more areas of assistance where rural hospitals and hospitals in underserved communities as well can go and get some immediate financial assistance. That's what I see a lot in my role, because we have some hospital administrators, they just need, you know, some cash to float their budgets so that they can keep their doors open. And I think that we're going to see that pop up a lot more following these cuts to Medicaid. And I think there's a huge rumor going around that the hospitals in states that did not expand Medicaid will not be impacted. I cannot stress how much of a lie that is. I think that we will be impacted even more because we did not expand Medicaid, so we were already behind the 8 ball, and now we're seeing an even deeper public disinvestment into healthcare infrastructure, so we're gonna even see us take even more of a step back. So I think that we definitely have a role to play here in DC, and I wish that we can get more immediate assistance, because I'm from Baton Rouge, Louisiana, and I was living in Baton Rouge when the state government decided to close Earl K. Long, which was a charity care hospital. And then right after that, our hospital in the North Baton Rouge area, which is a predominantly black area of the city, they closed all of their services down in the hospital except for the ER. And then the ER didn't even make it. So for a couple of years, North Baton Rouge had no hospital access. You would have to take a 30-minute drive across town. And this is in an urban metropolitan area. So I would like to see us do more for healthcare, because oftentimes our communities, and by our, I mean Black folks, we are the ones that are greatly impacted by these decisions more than anybody else.
Yeah, Yolanda.
I just wanted to, you know, at the end of the day, it's an economic decision, right? So unfortunately, it's limited on the community, but the voice, the processing, the resistance, it does work and it matters. It matters when they're making decisions. So my hospital system that I work within closed 2 hospitals, labor and delivery units, right? So right outside of Dallas, one east-west, because the system is saying, y'all just come downtown to the big hospital, right? But again, we only have so many beds. We only have so many C-section suites, operating rooms. So when I need to schedule care, it limits access to NICU beds. All of these things are taken in. But the hospital told us we're losing $1 million. We're losing $1 million a month keeping the hospital open. So when you talk about let's have these conversations, it's an economic decision also at the end of the day. I'm clear about that, but I'm also clear about what we prioritize, we pay for.
Every day. I kind of joke sometimes. I say in my next life I'm coming back as an economist. The epidemiologist can only do but so much. But to that point, Leo, so what's the end point? We're having this consolidation. It can't last forever. It can't go on forever. I mean, we can't get to the point where 80% of the hospitals belong to 2 companies. I hope we can't get there.
Do you really think that?
Well, no, I don't think that. I sure hope that doesn't happen. But, at some point, that runway has to end. I mean, this is about money, as you said. But if we keep removing care from people.
But it's about money. I was last week in Chicago, Becker's.
The hospital CEOs were saying a normal or a good operating margin is 3 to 7% for a hospital. President and CEO of Rush was there. He was saying his is 0 to 0.5%.
Yeah.
How when there needs to be investment, right now everybody's investing in innovation. He's like how his stomach is burning when his CIO comes to him. He has a 0.5% operating margin. So these are hard discussions.
Yeah.
When you're looking at those types of margins.
Yeah, look, I think the market will determine how much more M&A activity you'll see in hospitals, and that's just the truth. And so I do think the market is not going to go towards 8 giant health systems for the country, because I don't think the ecosystem landscape supports that. But I think the conversations about this is all regional. And again, I'll go back to Louisiana as an example. The conversations around in Louisiana of, okay, we have now 3 large health systems in the state. There has been consolidation. How do we provide the best care for our state? We all are vested. So a large health system is also very vested in the best care for the communities, because when you're Oxford and you're the largest healthcare system in Louisiana, you're also the largest employer. You have 40,000 employees in the state of Louisiana. And how your community's health and wellness goes, your employees' health and wellness goes. Plus, you're an anchor institution. So you're interwoven to the success of the state. And so I think that allows for a conversation. That puts you as a health system at the table, and it should bring the politicians to the table too. And I think in Louisiana for a while that did work, because I do think these needs to be public-private conversations, and they need to be public-private solutions to how do we keep access to our rural communities and our underserved communities. By the way, Louisiana's 60 out of 64 parishes are HRSA-dedicated underserved communities, not enough physicians. So we do need to be creative and innovative. The last thing I'll say is, for us in Louisiana, there is a looming cliff that you guys have already referred to. And if we don't peel back the Medicaid cuts, what we were able to do in Louisiana and keep rural hospitals open, that will become a significant crisis for the state.
Yeah. So I want to talk about the role of community. Gary talked about, we talk about the underserved. The thing that sort of popped in my head when he said that is we are still talking about the underserved. We've been talking about the underserved since, the Heckler Report. So that's 40 years. We're still talking about it. We still haven't somehow addressed this issue of why we have underserved folks. But as we think about sort of the role of community, because I want to come back to you in a minute, Leo, and ask you sort of what keeps you up at night and what gets you up in the morning. But Cameron, sort of starting with you, what does meaningful community engagement look like, given all that we've just heard in the last few minutes, but the stuff that you deal with every day?
Yes, I tell everyone, I love storytelling. I came in when you were telling the story about the 16-year-old. I think those are important. It's important for policymakers, especially at the federal level, when they're in DC, voting, they're doing committee activities and things of that nature. They still need to hear from the ground. They still need to hear from their constituents that this is what I'm going through. This is what's happening in our community, because we had a similar case in our community. When that hospital closed during COVID, it decimated ground ambulance. They have 2 ground ambulances that go back and forth. The nearest hospital is 45 minutes away. And we had a constituent who had a heart attack because he wasn't able to be transported in enough time, because the same thing, the ambulance was already taking somebody to the hospital and didn't have enough time to come back and take him. That's crazy. We're supposedly living in the best country in the world, regardless of how we feel about the things that are going on right now. And these things are still happening to, like you said, the underserved. Why do we have underserved people who are experiencing these things when we're also cutting deals and we're also voting in legislation that's going to give billionaires a huge tax cut so that we can have even further public disinvestments? It's time for us to really wake up and start really paying attention to what's going on in the political space, but also not being afraid to pick up the phone, call your representative, call the district office, you know, set up a meeting or something and say, hey, did you know this is going on in your own backyard? Because, and not just holding a certain party responsible, holding both of the parties responsible, you know, not just echoing and talking to, because we get a lot of phone calls. I'm not gonna lie to you, a lot of times when I pick up the phone, I'm like, have you called the Republicans? You know, because a lot of times I wanna know, because I'm like, look at who's making the decision. Look at who holds the gavel. Look at who's putting these bills on the floor. Look at who's bringing these decisions up, and hold them accountable, because we're, especially on the Senate side, we're not just, you know, one person's constituents. Both senators in each state are responsible for the constituents in their state. So that's my soapbox. I'll get off of it. But, you know, I think community engagement looks like us holding these congressional members in both chambers accountable for the decisions that's being made.
You heard it here. So, yeah. So Yolanda, from a provider perspective, what does community engagement look like? What do you want to see?
So what I would want to see is more transparency. And I love, because I think you're going to hear from each and every one of us, this accountability measure and factor. And so when you think about one of my concerns, nonprofit hospitals. I work in a nonprofit hospital I heard in one of the board meetings, a $7 billion, right, margin. And what does that mean? So I know that hospital has to do a community needs assessment. They're supposed to. They're supposed to take that assessment and address the community's needs. I know that they get tax exempt status because they are nonprofit. Community needs to be calling them to task. And so, but the community doesn't know what the community doesn't know, right? They go through these things, but this is behind, and the community has to be educated on this. So as you all are working, like translating that where the community understands, because it gets to the community, the words, the way it's framed, they don't understand what their power is in informing change or even just preserving their community status. So if you have tax exempt status, you make $7 billion, I know you have other bills to pay, but I need you to do what you said you're gonna do to keep that status. I see you looking at me, Leo, but you know what I'm saying. And so I do think, because I know they have to do a community needs assessment, and I know hospitals, often when they're opening and building and growing, they're talking about community need. So you use the community when you need the community to get more money and build bigger, but then how do we make sure you're returning that investment in serving the community and keeping the community and the patient centered?
So, Sherelle, hospitals, nonprofit hospitals, have to do community needs assessments. Does the community know that there's a community needs assessment happening?
No, they don't. They don't. And I also want to add to that too, because I'm so glad you said that. We need folks serving on these hospital authority boards. We need people with lived experience serving on these hospital authority boards. Typically, they're yes people for the hospitals, and we need folks that are going to hold them accountable. The other thing that comes with your community health needs assessment is nonprofit hospitals are mandated to spend a certain amount or invest a certain amount of money through community benefit spending. And community benefit spending should not look like health fairs and giving out turkeys for Christmas. But we're talking about real investment in, again, those social determinants of health. And hospitals do that across the country, but we're not seeing enough of that. We can be investing in things like, you mentioned telehealth. You can't do telehealth in rural communities if there's no broadband. And so we need hospitals, if you want to do telehealth in rural areas, invest in broadband so that that can be possible. Invest in, when I talked about earlier, the crime situation, invest in violence intervention programs, invest in housing. There's so many things that hospitals can do rather than draining from the community. As we're seeing in our area, we have a rural nonprofit hospital in our community, and they're driving up property taxes. They're buying up up properties in our community and just sitting on the properties and not investing. There's a lot of blight in our communities because of our local hospital. They're tearing down historic properties in our community and just outraging people in our community. I love what you said about your hospital in Louisiana. That sounds great. I love that for y'all, but that's not what we're seeing in our communities with our hospital, where there's even people that work at our hospital that can't even afford their own medical bills and are being sent to free clinics. And these are people that are employed with their local hospital. They're racking up medical debt and they're employed with their local hospital system. And so that even shows that the hospital is not even investing in its own employees right now. So a few things I do want to add in terms of what we can do as a community is we're actually working, one of our partners is working on challenging certificate of needs at the state level to ensure that there's language in certificate of need policies to regulate how hospitals close. You should not just put chains on the doors and signs on the doors and not notify the community. There should be a way in which you close your hospital that's responsible to the community. I would also say strengthening our local and reframing what we call traditional healthcare. Right now, our organization, we were one of the ones that recruited several people to become a part of our doula program, as well as our community health worker program. Hospitals reject those programs. They don't want doulas in their hospitals. And I live in a community where I have to call the name of Mary Frances Coley, who was considered the mother of midwifery. And she was the reason why generations of people still exist today, because she delivered so many babies in a way that was safe and secure and was even recognized on the worldwide level by the UN. We've got to get back to that. We've got to get back to having those traditional practices that worked, and they worked for a reason. So when you talk about, again, Georgia being the top for maternal mortality for Black women, we need infrastructure like this in our communities, and we need hospitals to recognize doulas and community health workers as non-medical professionals so that they can come into the hospital and be able to work with families. I also want to mention that there is something called a rural hospital tax credit program. If you're not familiar with that, we do have that in the state of Georgia. I think Alabama has that as well, where individuals and corporations can actually allocate a part of their taxes towards rural hospitals so that they can receive the funding that they need. And I think Georgia has a cap of $100 million, and you can actually select the hospital that you want to allocate those funds to. So those are a few of the solutions that I know would help turn things around in an era when people aren't investing in healthcare, or that our government is not investing in healthcare at the rate that they should. We can do something to change that as individuals. And then also I would say hospitals need to make sure that their boards and their upper level management reflect the communities that they serve.
So, Leo, Sherelle mentioned some things that have nothing to do with healthcare in terms of the role that health systems can play. But in addition to that, what does meaningful community engagement look like sort of in the conversations that you're having? You're talking to your executive leadership, you're talking to your board. You know, what does that, or what could that look like for let's say, for Oxnard?
No, sounds like I'm the defender of not-for-profit hospitals on the panel here. But let me just say, what is your alternative? For-profit hospitals and venture capitals buying your orthopedic and neurosurgery practices? That's the alternative. We need to improve our not-for-profits, because that is, every not-for-profit, as Yolanda has pointed out, has community as a fourth pillar. What they do with the community as their fourth pillar, that's a whole different story, but every not-for-profit has community as a fourth pillar. For-profit hospitals do not have community as a pillar. So I think I would implore you to work with your not-for-profit. They are under financial strains. They do run margins about 1% to 2%. When you look at pharma running margins of 20%, health insurance running margins of 18 to 20%. They are trying to do the right thing. And I love what the panel has brought out. Look, we need community representation on the boards. We need to have conversations about, okay, what is your community needs assessment? Who are you working with? You know, we work with the local health departments and obviously the community. I mean, that's important. Because if the community doesn't know what are you doing with the community needs assessment, and it's not transparent, and they don't understand, then you're not doing your job, right? So I think that level of partnership between the community and their hospital system, that's an anchor institution in your community, like we've talked about. If that hospital leaves, we've talked about the devastating life impact on people's lives, and this is truly life or death, not exaggerated, but truly life or death. So I think when communities and hospitals, not-for-profits come together, they do share the same goal. They do want improved health and wellness for the communities they serve. I think what we're missing is the dialogue. And there has to be a public component to that. There has to be a partnership with that state and those state officials. And when it's done right, I think it could be successful. When it's done right, it goes beyond just access to health care. It goes to public health. It goes to, wealth is health. It goes to economic development. When it's done right, I think that's the model we all want to strive for. And then the last thing I'll just, because I don't think we can underplay this. For not-for-profits to be successful, they are dependent on 340B. 340B gets cuts, non-for-profits will really feel that. For non-for-profits to be successful, they are dependent on Medicaid expansion. Medicaid gets cut, that will have an incredible impact on your state. And I couldn't agree more with the statement was made that if you think that you didn't expand Medicaid in your state, that somehow this is going to have less impact on you, that's just not true.
So I want to sort of...
Can I speak to that really quickly?
Sure, absolutely.
About the Medicaid not having an impact. I was just in Austin at the Capitol in Texas, and our Medicaid directors and commissioners, and they were saying the benefit for Texas, because we did not expand Medicaid, is that we now don't have to have work requirements. So that was supposed to make us, that was supposed to make us feel better. So that's how they're spinning it.
Meanwhile, in Georgia, we still haven't expanded Medicaid. And, Texas and Georgia are like cousins when it comes to these things, but we do have work requirements. Our governor created what was called Georgia Pathways that actually requires that people submit their work to be able to receive health care. And so if you don't have a job in Georgia, then you don't need health care.
But I just have to say, most people around Medicaid have jobs. They're working.
Thank
they have
you.
2 jobs.
Thank you.
Poor people are the hardest working people in this country. So the fact that we would further impose this burden on them is unconscionable.
Absolutely.
But I will now climb down off my soapbox. I want to sort of finish this session with sort of a lightning round question, which is, take a minute just to answer the question, but also give that call to action to the audience. So, Leo, I'll just start with you. What are the implications for provider training and education in a system that is accountable to patients?
Well, I think provider training and education really then talks about that community being your 4th pillar and really living the community as a 4th pillar. So when you're training residents, you're starting a new HBCU medical school. And by the way, this is my opportunity to give a shout out to the HBCUs because I hear about, they train 50% of the minority physicians in the country, and they're the ones who highlight research in areas like the APOL1 that we just heard. That is not getting light unless you have HBCUs that shine the light on diseases that disproportionately impact minorities. And so I think and there's a lot more health systems could do to partner with HBCUs if you go across and look at your HBCU partners. But it is that true community partnership, and it is training physicians, the next generation of physicians, to truly understand community as the 4th pillar.
All right, thank you. Cameron. Elected officials must be responsive to their communities. How can they respond to the needs of communities under the situation where access to care is threatened or eliminated? What do you want to see happen?
Honestly, I think the Dems have done a great job. Obviously, messaging, Dr. Yolanda pointed out, we need to be even better with the messaging, with taking these complex issues and making them translatable to the community so that they can understand what's going on. When my friends started asking me and talking about the big beautiful bill, most of my friends are more politically like engaged in me in terms of watching the news and, you know, talking about what's going on with the president and this and that. But when they were translating their view of the bill back to me and it was correct, that's when I realized, okay, we're getting the points out there. So I think that we just need to keep doing that type of work so that communities can understand what's going on in DC and how it will impact them. And also, just sitting here at this panel, I think the call of action to myself and other congressional staffers and members of Congress is that we need to educate ourselves so that we can speak back against misinformation. Because I really do hate how the public is being lied to. You know, this bill, these Medicaid cuts are going to impact they're not starting in 2027. They're starting this year. You know, a lot of the provisions, not a lot, but some of the provisions are going into effect this year. You know, and so we need to do a better job of getting the public to understand this is what's happening to you, this is how it's gonna impact you. Well, this is what's happening in DC, this is how it's gonna affect you. Because even in Louisiana, I'm hearing from some of my friends and family members about, you know, how they didn't ever have to like re-enroll in Medicaid, and now they're getting paperwork in the mail, they're not completing it, and they're getting pushed off the rolls. That's because of HR 1. You know, so we need to get that messaging out there.
And that your vote matters, the implications of your vote.
Yeah. Yolanda, can providers earn a living in a community-driven health system if we had true community engagement?
I believe you can. I believe providers can. I think it requires particular skill sets. I think you've got to adopt innovation, and you've got to. There's no other way. I do believe you can. I think that oftentimes, you know, certainly as a physician, our head is down in the sand. We're just working. We are working. You know, anybody that's working 100, 120 hours a week, you don't have a lot of time to process. You don't even have time to think about strategy. But there's available opportunities, right? I currently work also at a community-based organization where over 70% of our clientele is unfunded. So we're using grants, we work with the state, we do all types of things to get people care because most people can't afford the care. The model that we use, yes, so we make it, we sustain, we have staff, we pay our staff fair wages, we do that, but you have to be creative, you have to adopt technology, and you have to build collective partnerships in your immediate community and area.
Absolutely. And Sherelle, last question. What is the role of organizers and advocates in both the acquisition process, but the care protection process?
Yeah, so we tend to be the deliberators between the community and the people in power. And I want to say we have to find a way to stop the commodification of human beings in our healthcare system. I love what you said earlier, we have to tell more stories of people that have lived experience and how they're experiencing our healthcare system. Because if we're honest with ourselves, no one is enjoying the American healthcare system. None of us, the physicians, the nurses, the community. And so we have to get back to community co-design. Like, how do we build hospitals that center the humans, the people, the lives of the people that are in the community? And how do we get to the tables with people that run the hospitals? How do we have community conversations where we're designing what we want our healthcare systems to look like? When we talk about no one's enjoying this, and I hope I can share a little bit about something that I know we're working on with Community Catalyst, is Community Catalyst had an opportunity to really measure and create what they're calling a harm index that measures the harm that we're experiencing from our healthcare systems. And I actually thought that there's a tiered system, that if you have private insurance, you're getting the best care. If you have government programs or Medicaid, you're probably not getting as great care. And then if you're uninsured, you're getting the bottom of the barrel care, right? But that's not true. According to this health index, none of us are getting quality care, no matter what your insurance is or no matter how you enter the healthcare system. And so that's an indicator that something has to change. If you can go to other countries, and I know you mentioned that we are probably one of the best countries in the world when it comes to healthcare, we should be, but we're not. I've actually had a chance to travel to other places like Portugal to see that they're not having these types of conversations. They're not talking about healthcare costs. They're actually making sure that their people are taken care of and that their healthcare is something that they don't have to think about when it comes to costs. So it's something that's entirely possible because it's happening in other countries. Why is that not happening in America? And so I think we have to sit down together with our healthcare leaders, with our hospital leaders in our communities and start to build trust again, but also start to have some real conversations about how do we create a system that works for all of us and does not cause more harm to our communities and to our people in America.
Thank you. So we heard a lot today. Hopefully you all will kind of take this in. Decisions are being made about what services survive, what hospitals stay open, whether families can have to choose between a mortgage or healthcare or medicines or their insurance premiums or sending their kids to school. And these choices are being made and these decisions are being made without the communities, the very communities that we're talking about who are most impacted. And I would say this isn't inevitable, this is a choice. As they say in tech, it's not a bug, it's a feature. But it's also a choice that we can change. So I've got a couple thoughts. If you lead a healthcare system, let the community benefit obligations you carry be transparent to the community. Let them know what that is. If you shape policy in the next 12 months, we know that that's going to determine whether the antitrust reinforcement in healthcare has any teeth or whether Medicaid survives intact. Make sure you call your Congress people. If you represent pharma or payers, affordability is not just a patient problem. It's a market integrity problem. And when people can't afford to use the system fails all of us. To your point, Terrell, none of us gets great care. And for all of us in this room, the communities must be at the table before decisions are made. They need to be able to participate. They shouldn't be just invited after the decisions are made. They should be respected and valued because these healthcare decisions affect them and their health. So we have to build the capacity not only to advocate, but to negotiate. This moment is urgent. The solutions exist. I hope you're all leaving with some glimmer of hope. But what's missing is the will to prioritize people over profits and the accountability to make sure that happens. Thank you to my panelists. Please join me in thanking this panel. And I appreciate all you've done today. So I will check with the organizers. Do we have time for questions? No. We do? I don't know.
No, we don't.
Did you say no?
You said no.
Sorry.
Hard no.
Thank you.
Thank you.
we're here at NKU for the 2023 second annual Northern Kentucky Youth Summit. We are here today to talk about a very important topic, which is suicide prevention and empowering young mental health champions. So we're here with over 21 schools, over 200 middle and high school students across Northern Kentucky.
It's okay to share your mental health. It's okay to stand up for yourself because it's important and it should happen.
So WellCare was very instrumental in starting this Community Impact Council, as well as being our key sponsor for the event, and have been carrying forth this Community Impact Council across the state, so not just in Northern Kentucky, to really provide some more support for our young people that really need it at these moments.
Good morning, everyone. My name is Diana Rubio. I am a family physician and a Commonwealth Fund Fellow at Harvard University. I will be moderating our session today on youth mental health and how to support our adolescents. We are aiming to keep this session conversational, and we do have time left at the end for question and answer, so please don't be shy and come up to the mic towards the end. And with that, I'll turn it off to our fabulous panelists that we have here today, and I'll start with Mitchell.
We good? There we go. All right. Good morning, everyone. My name is Mitchell Kuhlman, and I am the manager of youth safety and well-being for Big Brothers Big Sisters of America. We're the nation's largest one-to-one mentoring organization. We pair our youth with trusted, caring adults, hopefully with an impact that lasts a lifetime. My background is in youth mental health and also child safety. I spent some time at the National Center for Missing and Exploited Children and also the Zero Abuse Project. I also sit on the board of the National Coalition to Prevent Child Sex Abuse and Exploitation, where we advocate for certain policy changes in the world of child protection and focus on national strategies to keep our kids safe. I want to thank Centene for having me here today. Super excited for this conversation, and I'm super excited to learn from all of y'all.
Thank you. Good morning. Crystal Brown, I'm the Chief Program Officer. That was my maiden name, Crystal Brown Garant. Been married for 5 years now. Crystal Brown Garant, Chief Program Officer at Sandy Hook Promise. Sandy Hook Promise was founded December 12th, 2012 after the Sandy Hook Elementary School shooting. And our commitment is to keep kids safe. And the way that we do that is thinking about how do we build skill sets and mindsets around prevention, how do you translate to behavior, and the role that trusted adults play in that relationship. We focus on the programmatic aspects, but most importantly, policy and thinking about what do we do to create durability in our systems to ensure that when programs are gone, there are legislative acts in place to ensure mandatory violence prevention training and suicide prevention training in schools. My background is in positive youth development. I spent the balance of my career with Boys and Girls Clubs of America. So I really believe when you give young people knowledge and skills, they can actually sit at the table and be a part of the solution. So looking forward to this conversation. Thank you to Centene, Big Brothers Big Sisters of America as a partner of us, and grateful to be here today.
Well, good morning. I'm Tremaine Elamine. I am the Vice President for Mental Health First Aid USA, as well as a number of programs at the National Council for Mental Wellbeing. We are an organization that is focused on the policy and advocacy of the nation's community mental health safety net. We focus not only on mental health literacy and building mental health literacy in the community, but we also focus on ensuring that people everywhere have access to timely care and that well-being can truly be for all. I'm excited about the conversation today. I just came in from 6,000 of our best friends at our national conference in Denver, and I will tell you that this room, in addition to the rooms that I was just in, just remind me of how it takes all of us as a community to really make impact. And so I'm grateful to be here, grateful for Centene and to the other panelists. I feel like we're like a group of road tripping, around bringing and spreading the good news around mental well-being across the country. So thanks for having me today and look forward to the conversation.
Good morning, I'm David Diaz de Leon. I'm a pediatrician and I work for the Centene subsidiary Superior Health Plan in that special state that someone mentioned on the last panel, Texas. So I am from that state and here to discuss the role of managed care in youth wellness and how that can enhance overall healthcare models and overall health in general. So happy to be here. Thank you for having us.
What a treat. David, we will start off with you. You have a very unique vantage point as a pediatrician, chair of a health plan committee that provided funds for the Uvalde Healthcare Center, and also for a managed health plan. You see data across thousands of families in Texas. What does the data actually show about youth mental health in America right now?
I can speak to at least the Texas market and how that looks, and I would say there's a definite rise and increase in claims for children who are seeking care for anxiety, depression, and crisis intervention. That is compounded by barriers to access to care due to lack of financial resources, lack of services in particular service area, and or long wait times to try to get into those places to get the care that they need. So I think that is where the role of managed care can be highlighted, and you can take a look at what it really does. I know when people hear managed care, they think insurance and paid claims and paying out bills, but it's much more than that. It's a much more involved process. Managed care organizations such as ours employ nurses, social workers, licensed counselors, a whole gambit of people coming together to impact the care of our individual members. So, and going forward, the value of managed care and that aspect is invaluable, and it's a team effort. It's consider it a coordination of care model. It is not just again, like playing claims. It's more so the ability to use that information, come together as a group and coordinate care for the entire person, and not necessarily just their benefits. So.
Yeah, thank you so much for sharing that. As a family physician, I definitely as well have seen the uptick in youth mental health and anxious and sad adolescents, and what does that mean for us, and what do the benefits of managed care organizations provide in terms of team-based care and whole person care. Back in your community when the Rupp Elementary School shooting happened, can you tell me about how Uvalde responded?
Certainly, I want to speak to this with great reverence because it was a tragic situation, but out of that situation came a lot of good overall for the community. Around the period of time that it happened, there was an immediate response by our managed care organization to go and provide immediate resources. We contacted our members. We provided trauma-informed care trauma-informed care training to various clinics in the area. But we needed some sort of long-term plan to assist community because it was definitely going to be. They were going to be impacted. They were going to have this long term. So we coordinated collaboration with the local federally qualified healthcare center and built a relationship with them, spoke to their leadership, got their needs understood a little bit more, and offered our services and built a strong relationship with that community center. Over time, that has evolved and grew into a continued collaboration with them. Culminating in the opening of a brand new community center last summer, which was an honor to be a part of that opening. That was really special. The core concept of what I stated earlier about coordination of care, and it's a care model, has transitioned into an actual physical place where that coordination of care actually turned into direct patient care, but in a multidisciplinary manner. So this community center that they now have has the ability to provide physical health services, a lot of behavioral health services, dentistry. They need an x-ray, they can get the x-ray there. If they need medications filled, there's a pharmacy in-house. And I believe Big Brothers Big Sisters offices there and provides services there. There's youth transition specialists there, as well as counselors assisting youth to transition into the workforce, should they desire to do that at that age. So yeah, a lot of benefit that center provides. It's an anchor in that community, and will be an anchor there for healthcare for years to come. So.
That sounds wonderful. Thank you so much, David. Tremaine, we'll have a few questions for you. Your organization has trained teachers on mental health first aid following the Rupp Elementary School shooting. Can you tell us a little bit about what mental health first aid is and how it works?
Absolutely, absolutely. But first I want to ask, how many people could have used a little bit more information in the room as a young person about what their emotions were, what mental health was? Anybody? Yeah, just about everybody, right? And I think that when we think about education in our communities, we're now at a different place than we were. I would like to think that we've had a little bit to do with that in terms of pushing for policies and requirements around ensuring that mental health literacy and mental health education is something that we pay attention to. And I think that our collective efforts has resulted in us being able to have a program and a tangible program that teaches people, just like you would for CPR and first aid, how to recognize when someone is in distress, whether that's a crisis or a non-crisis situation. But it's also about making sure that that conversation is not weird, not awkward, that we don't hesitate to jump in and to support somebody just because we don't know the exact words to say. And Mental Health First Aid is a program that teaches, just like CPR has those like steps, and you remember singing the Staying Alive song when you get trained in that, right? You remember those steps, you remember mnemonics, and so we have a mnemonic called algae. It sounds like pond scum. It really is just the name of a koala. And it helps us to remember to assess the situation, whether that's a suicidal situation or a situation that's a crisis, and what are you really engaged in. It helps us to listen non-judgmentally, and all of us think we're good listeners, right? Until we get in relationships, right? And then giving reassurance and information, not just telling people everything will be fine, but how do we give the right information, good sources, the right kind of content, and then encouraging help in two ways, whether that's professional help or encouraging other kind of support strategies. And really community care can be one of those strategies that I think is really important, especially as we think about access to care and that connection back to that. We've trained 4.5 million people in the US and 8 million globally. I like to say mental health first aid is for anybody that has a heartbeat. And we're in thousands of schools across the country. Why? Because what we recognize is that we can no longer wait to have this dialogue, and young people, we gotta catch up. They're already having this conversation, but we want them to do it with the right resources and with adults that have the right information about where to go and what to do. And so this day-long course helps them do that, but more importantly, it's not about training. Training is only one component of what we teach. It is about making sure that we're transforming communities, transforming hearts and minds, to know that not only is help and hope available, but also that there are specific resources and people who can help when those shortages that we see from the higher level of acuity needs. What do we do in the meantime? And how do we hold space for healing while we're seeking help?
Thank you so much for that. And as a part of our conversations and preparing for today, we talked about mental health literacy. What does that mean for those of us in the room that don't have any background in this?
Absolutely. I liken, it's not just what it is, but it's also how we do it, right? So when we think about our literacy, we know that we have some challenges in our country in terms of just literacy overall. And we also have opportunity to put interventions in place to give enough information that changes, first of all, the knowledge that someone might have. So increasing knowledge around what mental health is, the fact that all of us have mental health, and that's on a continuum. I think it's also about making sure that not only is there knowledge, but there's intention to act, right? If we go from a public health perspective, are people being willing to act and intervene at the level that they're comfortable with the skills that they have? I often emphasize, you do not leave a one-day mental health first aid training, and now you can get a cute couch, charge billable hours to listen to your friends' challenges. Okay, it doesn't work that way. It really is giving you just enough information to stay within the guardrails of your knowledge base, and then also to refer someone to care. We want to make sure that the skills that are built in that room, when you think about literacy, can you transfer those skills not only to action, but then have that retention over time? And what we see as a result of mental health first aid, but also other training programs that really focus on mental health literacy, is that when you want to see people be able to take that information, take it into tangible action, then over time start to see population level impact. And that is what that impact of literacy is. It's not just about the knowledge base, but it's also what do we get to do and what do we get to see? How are we connecting to other community care needs? Someone earlier on the panel was talking about community health needs assessments. And we've seen mental health first aid be part of that impact to what we do in communities to address the various needs that come up in those health needs assessments at hospitals across the country.
Thank you so much for sharing that. When I think about youth settings where we're helping the youth, I'm thinking about schools and healthcare settings, but where else are we helping youth that are usually forgotten that we should think about?
Well, the good news is you have two other people who are going to be on this panel that are to my right. He'll tell you about some of those spaces. But what I will say is it's been phenomenal to see young people at the forefront of this conversation. And I always talk about, and many of you in the room who work in healthcare, talk about doing things with people and not for them. And that's what we've done with our programs. We have a teen mental health first aid program that's not only being taught not only teaching young people how to find that trusted adult to talk to get support, but also how to maintain a friendship as a person might be struggling and get to safety, right? Teen mental health first aid is about teaching young people what resources are good and how to get them connected to a trusted adult, whether that's a parent, a caregiver, a guardian, a coach. And so if we think about youth sports, if we think about gaming, if we think about spaces where young people are when it comes to congregating in youth-serving organizations, not just in schools, we're seeing the content being leveraged to build community among the young people, but also the trust among adults. Because all of us wanted that trusted adult, right, as a young person to talk to, but everybody's not trustworthy, right? And so how do we ensure that we're equipping not only the young people with the right information, but the adults in those youth-serving environments? That's something that we're really focused on and something that we're seeing real impact with. And why do we know we're making impact? Not just because of numbers and statistics and feedback, but because the young people themselves are saying that it's effective and impactful. And that's my measure of success.
I love that. Thank you so much, Tremaine. Crystal, let's move on to you. Your organization was born from the Sandy Hook shooting. Can you tell us a little bit more about your organization and Know the Signs PSA?
Sure. I remember where I was on December 12th, 2012. I was at a Boys and Girls Club, out of school time. And the first thing that we did, I was at our headquarters. They sent all of the youth development professionals out to the schools that we served to make sure that young people got to the Boys and Girls Club safely. And I remember that because when I decided to venture out of youth development and come to Sandy Hook Promise, I wanted to understand what does it actually take to create a culture of prevention? Not just language, but what are the systems and structures and how they work together? Our organization, while born out of tragedy, held onto two things. One, how do we build enough public will, enough public belief that young people deserve to go to school and come home? And it has taken 10, 11 years to start to mobilize people around common sense solutions. So one, it has been about building public will that prevention is possible and prevention is a response. Secondly, this has really been about how do we help students, parents, educators know the signs. So we have studied every FBI report, Department of Homeland Security report, after school shootings. The theme is that there were always warning signs. There were young people who were isolated. There were young people who had a track record of not coming to school, being school avoidant. There were young people who were juvenile justice involved in every single report. And so we translated that to programs to say, how do we help young people, their communities, know the warning signs when someone is at risk of hurting themselves and others? So that was the second objective of the organization. I said 2 things, but there's really 3 things, right? We want to make sure that there is collective ownership of the problem. So thus far, we've really looked at how do we drive legislative mandates. The first piece of state-level legislation that we passed was the Save Students Act. That was passed in Ohio, that mandated 1 hour of violence prevention training, 1 hour of suicide prevention training, and youth leadership clubs, because we know youth move with their feet. And this was about teaching young people how to know the signs, how to lead effectively, how to communicate solutions, how to identify problems, and then partner with their superintendents, whether that be at the local level or state level, to really drive more protections for young people. We have recently passed that same piece of legislation in Louisiana and Georgia, most recently with House Bill 268. I live in Georgia, and my young person is a public school student in Georgia. So I'm proud of that kind of 3 anchor strategy. I think as we move forward, we have more work to do on public will. There are still people who believe that this is inevitable. It is not inevitable that your little person goes to school and they don't come back home. And it's not inevitable that young people pass active crime scenes on their way to school, which prevents them from going to school. So I'm very grateful for the ways in which our organization has thought about how do you build knowledge and skills, how do you build public will, and how do you create durability in systems. I think we have a lot of work to do in terms of who are the other stakeholders around the table. For example, we're working with Arizona Department of Education. So much of our strategy was about the work in schools, how do we help professional learning and know the signs. But what we realized is nurses were being left out of the equation. And what nurses were telling us is, well, we're just there to put a Band-Aid on and get them back to class. And I said, okay, great. But can you ask an open-ended question to see if that young person is doing okay, right? So much of this is about building relational trust and not assuming that those people who might have relational trust know how to build relationships with young people or to be that trusted adult, as Tremaine mentioned.
Thank you so much, Crystal. I feel like a lot of the times when we're having these conversations, we talk about the need for political will, but we don't really transition and reframe it to public will and what does that mean and getting things moving. All right, Mitchell, on to you. Research shows that one of the strongest predictors of mental health, resilience, and thriving in young people is one adult caring about them and believing in them and showing up consistently, as we've also heard from Crystal and Tremaine. Big Brothers and Big Sisters is really intentional on mentoring, and can you tell us more about the work that you do in your organization?
Yeah, absolutely. So at Big Brothers Big Sisters, we are a one-to-one mentoring organization. So we pair youth with caring adults with hopefully an impact that lasts a lifetime. And what makes us so important and effective in what we do is it is structured. We don't just take one adult, one youth, and say go have fun. Like it is a system that is rooted in safety and quality. And so kind of how this process works is you have a volunteer who kind of goes through background checks, screening process, interviews, references, all sorts of things that my team, has established to make sure this is a safe match. And so then you have a young person that we have likely on a wait list. We have 30,000 kids right now on the wait list who need mentors, who need caring adults in their lives. So that's something that we need to work on is shortening that wait list. And so what they do is they have these youth that are ready to be matched. And so they look at their lived experience, their personality, their traits, things they like to do, things like that. And once they deem it's a good match, then they move kind of on to the next step where it is under the watchful eye of our match support specialists, our program directors, safety specialists, people like me, kind of help them along the way. And also we involve parents heavily in this process. So our parents and our mentors all take mandatory trainings on trauma-informed care, youth protection, and mental health, and we offer a whole bunch of other initiatives and trainings to help recognize and respond to kind of mental health challenges in youth. And so we have this very structured approach, and we're very proud of what we do. We just had a study release that determined that 20% of kids who are mentored are more likely to attend college. They also have 15% higher earnings over a career of a lifetime, which is something that we're very proud of. And kind of what we're talking about is having safe and stable adults can make all the difference. And so one thing you hear me probably say a couple times today, people always say, like, I can't be a mentor. I'm not perfect, right? I've made mistakes, but it's like, maybe I can't be a mentor. But it's like, you don't have to be perfect. You just have to be present to make a difference in a young person's life.
Thank you so much for that, Mitchell. We don't have to be perfect. None of us are. We just have to be present and provide that psychological safety. Can you tell us more about the mentor-mentee relationship? How long does that usually last?
So it kind of varies. Usually the typical kind of commitment is around a year, but we see one of our stories that we highlighted in this recent report that we just released. I'll try to get this right, stick with me here. And so it was an older gentleman who wanted to be a mentor and volunteer and give back to his community. He took on a little, I think it was about 10 years old, and so then they maintained a friendship up until the little was then grown. And so then wanting to give back to how transformative it was for that little then took on another little in the program who was around the similar age. And so there's a really great photo too of all three of them at a wedding and who have made connections that they had not made before. And it just really has that protective factor of just having your community be broad and having just these opportunities that become open to you that you never thought existed, but it can be quite a very impactful thing. And when you look at those success stories and people say, what does that actually look like? It's just probably an hour, once a week, a couple times a month. It's not that crazy amount of people think it's something. A huge undertaking that you have to be certain away or do all these things, but it's just hanging out with someone. It's just going to an art gallery or going to a Phillies game. I'm from Philadelphia, or going to a baseball game. And it's just being there for the young person and just giving your time and having your undivided attention to know that you're in their corner. That can make all the difference in a young person's life. And we've seen lower rates because of that. We've seen lower rates of anxiety and depression and suicidal ideation. And kind of what Tremaine was talking about, I'm certified as an instructor for youth mental health first aid, so I know all about algae. And so we train our mentors, and we have these trainings for bigs as well, so they can respond they can recognize and respond to potential mental health challenges. Because what kid is going to come to you and say, hey, I've been really struggling with X, Y, and Z, right? That's just not going to, most likely that's not going to happen. So it's on us as caring adults to recognize these symptoms and intervene and kind of ask them just, how are you doing? That could be a good way to start the conversation. But very long-winded answer, but we're very proud of the work that we do.
Thank you for sharing that story. My next question for the panel is on artificial intelligence. It's been a hot topic this past year. So there's a growing conversation about AI and mental health screening, chatbots for crisis support, and all of these algorithms. Some are hopeful, some are concerning, especially for youth, because there really aren't any guardrails. What's the potential and what are the dangers in your opinions?
I'll take that first. We are actually working with a few thought leaders in this space to understand how do you design to raise awareness on the warning signs of violence. And so talking with the coders to understand if a young person says, how do I, take my own life? it then is able to flag a particular algorithm that shuts that question down, that diverts to immediate support and care. Many companies are thinking about this and trying to say if someone over time is asking similar questions, that it will flag to a certain department and that department will intervene. You can imagine the complexity because we already have fragmented systems. And so one of the questions they're asking of Sandy Hook Promise is, if we see something in a particular region of the country and we're able to get the IP address, can we revert that to your National Crisis Center? And I said, well, let's try it out. I think the challenge for us is you can divert it to our National Crisis Center, but if we don't have a relationship with the public school system, that information has nowhere to go other than public safety or local law enforcement. So I think that there are some very productive conversations happening. Unfortunately, we are reacting to a number of traumatic instances where young people have been successful in their suicidal attempts because the algorithm gave them the information. So I am hopeful that there are companies who are thinking about how do you code to flag in order to get a young person help, not in order to connect them to the justice system. So there are conversations happening, but we have a long way to go in terms of how AI is leveraged and how young people understand how to use it as a productive tool, right? So we go back to literacy and we go back to the importance of youth development professionals, educators, not shying away from AI, but saying these are the productive ways in which you use it and being comfortable to talk about those unproductive ways that infringe on mental health.
Yeah, first of all that, I'm so interested, so we're going to have to, okay. So I am so interested in what Crystal is saying because there's this, at the same time that you all are having this conversation, there's this increase in loneliness among our young people. 3 in 4 young people are using AI companions, right? And 2/3 of them are using it specifically to really address their own well-being. And the answers they get are great, right? When they type everything into the chat bot, right? They're not. The answers aren't wonderful. The answers aren't giving them actual good information all the time. But yet, they will not stop using it, so we need to make it better. We need the system to work in a better way, and I love where you were going, Crystal. I think the other piece we need to do is literacy about how to use them effectively and what they do and do not do, right? And so I think that part of what we're doing is incorporating how we talk about AI companion use. There's some wonderful organizations out there that have done a ton of research and are thinking about how to, from a public health perspective, give information to young people through campaigns, through PSAs, to ensure that young people have an understanding that what you put in, you put garbage in, you're going to get garbage out. And sometimes if you could put a good question out there, you still get back reflected what the collective content is that's out there that is not curated for a specific answer. And so I think that there's such a need to educate and promote literacy around how to use these tools that we have, because they're all tools. They're not going anywhere. I think also as adults, a lot of times we say, well, just turn the thing off. Just don't use it. No, less screen time. And while I think that some of those things are helpful, we have to be realistic about where we are. We are moving at the speed of light almost when it comes to how quickly these systems are adapting. And I think it's about reframing for young people the importance of human connection and ensuring that we start to really focus on, perhaps it's just a 2-hour, let's go grab some coffee on a Saturday with no phones. And that's the adults too. Right? Perhaps that's ensuring that, how much time are you spending with your friends doing nothing that's on the screen, right? Asking those probing questions. Could you try this or try that? Giving them the tools, because when it was about the street lights when I was young, you come in, right? It's street lights on, you come back in, right? And so that's just a different thing. I have a wonderful child and adolescent psychiatrist that I know, happens to live in my house. And his statement that I love so much is that the playground of today is online for young people. What we went to do from a playground perspective, that playground is online. So if that playground is online, can we please help them use that playground effectively?
And yeah, I'll jump in because she said the buzzword, human connections. We are all about human connection at Big Brothers Big Sisters. And so speaking with AI, and I won't scare you all about the child sexual exploitation side of things at 10 a.m. I'm not going to scare you guys, won't go that route. But we do see we're talking with AI companions and focusing more on the youth that turn to them for support. And like Tremaine was saying, they don't always get the best advice or guidance or things like that. And that's where we can have an opportunity where Big Brothers Big Sisters fits in. So if the youth is turning to AI for companionship, for friendship, for connection, that's where we can have a safe and trusted adult to be that connection, to be that kind of bridge into different activities. And some of the youth that we work, and like she was saying, the online space is not going to go away. So there's tenets of online safety and digital citizenship that we can follow to make sure our kids stay safe online. But some of the stuff that we kind of tell the youth that we work with is go find hobbies that you're interested in. And one of the youth that we work with was huge into skateboarding. And so when he was in the program, he really loved to skateboard. And so his mentor was like, if you really love to skateboard, go find, other kids who skateboard, you might, And so then now, 10 years later, he refers to them as his brothers. Like he found some community and he found that belonging. And so it's not that AI is going to go away and that we should shy away from it. It's using it responsibly. But then also making sure we don't lose those human connections, those human relationships in the process.
Yeah, I couldn't agree more, but listening to everyone speak, it sounds very reminiscent of what the advent of the internet was like when it first came online in the late 90s and the fear that it brought along. But it became a tool, and no one would have expected in the 1990s that it would escalate into us using it daily on a phone in our pocket every day. So how to use it wisely, I think, is very, very important. I know in our space, we're trying to utilize it to reduce all of the mundane tasks of filing, going through files and all of those things. But the human connection, I think, like you said, is very important to maintain. That would be the guardrail, I think, that you were maybe alluding to, is that how do you regulate that? You take the information that's not important, but you distill it down to something that people connect with, so you can use that information in the space where the child needs that intervention as best as you can.
Thank you all so much for those comments. We could go down a rabbit hole on AI, so I'm going to leave it up to the audience if they want to ask more questions about AI later on. But I'm going to switch over to advocacy. One of my favorite quotes from President Obama was that the change we need doesn't come from Washington, it comes to Washington, and you all are working in such fragmented systems with fragmented data and are doing incredible work. Can you speak to some advocacy or legislation that we should look into to further advocate on or push forward?
I'll start. So I think that the success we've had around the Save Students Act, again, appropriating and mandating regular training in schools is a place to start. I think that there is opportunity to push that legislation further to include out-of-school time. One of the things that we are advocating for is that it's not enough to just pass the legislation, but you have to appropriate funding. And so as we work with the Minnesota legislator after the Annunciation shooting, you can imagine that there were a lot of folks interested in the legislative side or the advocacy side of keeping kids safe. And so that is an approach that we're taking and carrying that legislation forward. Again, my 10-year-old goes to a public school in Georgia, and I'm excited that as part of back to school, as part of coming back after breaks, they will have violence prevention and suicide prevention training in schools. And actually, my little person had encountered some bullying where we had to take her phone away. And the one thing she told me, she said, you know what, Mommy, if Mr. Barnes was able to do some programs, that's what she said, some programs around how do we create connection and reduce harm, that would be really helpful to me. And I said, you know what, Rumpy? That's what I call her. Her name's Jubilee. I said, you know what, Rumpy? There's actually legislation to make that happen for about 4 million kids, and we want to continue to do more of that. But I think that where it starts is around the public will. So me as a mother, as a citizen, calling my representatives and saying, I want to keep my kids safe. I want to know that when Jubilee goes to school in DeKalb County, she's going to come home. And we've had a lot of success with representatives. They get it. It's common sense. And if we can help them then turn that into legislation that facilitates action, that's where we start. But I cannot underscore that legislation without the appropriation of funding to actually do this work in schools, we have to have both, and so need your partnership in that.
Hop in. So every year we have, for the last 5 years, Big Brothers Big Sisters is active on the Hill. And so the last 5 years we've had our annual Capitol Hill Day. And so what we do is we bus in and fly in agency leaders from all over the country. Our agencies are kind of like our local chapters. We have 230 all over the country in all 50 states. And so we have all these local agency leaders come in and advocate to lawmakers on the Hill. We also bring in youth to advocate for bills that we are hoping to get sponsored and have championed. And so one of the ones that we're working with the last 4 years is the Rise from Trauma Act. And so what that does is that helps bridge the gap between youth-serving organizations and community mental health partners. It provides funding, and so like that is the biggest thing that we need in this work is it's not that our agencies don't know that they need to train and have resources on these things, it's they don't have the capacity and the funding. So like the biggest part of that is just give us money. We need to do this work. And so that's been very successful the past 4 years. And so we've had also young people with us. Our National Youth Council sits in these meetings with lawmakers. And this past February, I was with one of our National Youth Council members from Oregon. And so we're going to different, House meetings and Senate meetings. And she was like, I'm not going to talk, right? Like, you're going to do all the talking. And I was like, no. I was like, here's what I'm going to say, here's what you're going to say, and you're going to talk to these people and advocate. And so like, I didn't realize it until just now, like that can be the power of mentoring is, it's actually, I just didn't realize that till just now, but like just having somebody that said like, yeah, you got this, you're fine. Like, it's not that scary, they're just, a staffer, like same job, put their pants on one leg at a time too, right? And so just having that confidence instilled in that young person to be like, yeah, go for it, you're good, and to be there along the way. So pretty much we just are very active in sponsoring, and not sponsoring, but supporting legislation that helps mentorship thrive.
I've got one to add to that, and I wanted to thank you for sharing those. I'm definitely going to follow up and share more about those. I think it's also about how do we address existing legislation as a part of this, not only advocating for what we want to see happen. One of the things that we focus on, I mentioned we're an organization that's been around for more than 50 years, and right now, the Bipartisan Excellence in Mental Health Act is something that we're really pushing. We're so excited, has been introduced to really support our efforts around certified community behavioral health clinics that have been really successful across the country, to see them continue to be supported. But it is also about preparation. On the last panel, I was so heartened to hear about the emphasis on what the impact of HR 1 could be, and the fact that the preparation for that, especially among community behavioral health centers who do have those small margins, who are nonprofit in origin, and how they execute impact into the world. It is so critically important to help them understand how to prepare now for the impact of legislation that comes later. Because often we're in an environment, let's be clear, that we have to do more with less constantly. I like to say, if it's bubble gum and paper clips and bobby pins, we put it all together and we make it happen in nonprofit land, right? But it really is about making sure that we prepare well for the future, but create the urgency of now. And I think that that's part of the challenge, is sometimes we have to walk and chew bubble gum. We have to focus on the future, but also the impact of what that future looks like, and really stressing to communities that often we don't see it until it hits us in that moment. And it's about not only what we want to see with new legislation, but how do we prepare for the impacts of existing legislation on our future.
Yeah, it's interesting you say that, because in my role, I have to implement the impacts of the legislation. So one of the highlights of my position is to be able to work in the foster care community. Our Star Health plan provides benefits to all children and youth in foster care, which is about 32,000 children, I think, throughout the state. And coordinating care for them involves all the changes in legislation, all the things that have come through the last legislative session. So we've come up with direct lines of communication between our HHSC partners as well as our Texas Department of Family and Protective Services. We have weekly to bi-weekly meetings. We interface with them regularly. So it's interesting that we're talking about advocacy on that end, but we actually have to implement that in the realistic world and how that works. So yeah, it's an honor to be a part of that too.
Thank you all. So you heard it here first. There are 3 acts that were talked about today: the Safe Kids Act, the Rising Trauma Act, and the Bipartisan Mental Health Act. So when you go back into your communities and you're building that the public will, those are places to start. And this will be my closing question for the panel. So please start coming up to the mic with your questions if there's anything that you still didn't get answered today. But to close out, we've talked about mental health for youth, and it can be a very strong topic to talk about early in the morning. What gives you hope?
I think I'm one of the older ones on the panel, so I'll say this. It's like back when I was younger, there was a social stigma associated with mental health and seeking mental health services. It was something that was put away. It's like, oh, you're just anxious, just get over it, or just move along, or don't talk about it. I see in not only just my children, but other children that I've been encountering clinically and other venues, that's maybe not there as much anymore. That they talk about it more, that they're more open to learning more about it and communicating with each other about it than before. Whereas when I was young, it was like you don't talk about it at all. And I'm just curious to see if you all are seeing that in your spaces as well, or not. So
Conversations are getting easier, maybe, or more visible. Mm-hmm.
I can echo that too, on a personal level too, as a kid growing up who was not really encouraged to share how I felt or have those feelings, but anger was accepted. That was the one, especially for men, that's the one that's accepted, right? And so I think, so what gives me hope here is kind of twofold. Continuing on the topic that you're talking about, anecdotally, I'm super happy to see like men in mental health represented in like major television shows in a different way than it has in the past. That comes to mind is the show like Ted Lasso, right? If you know anything about the show, you know that Ted goes through some mental health struggles, and it's okay to not be okay. And I also like how there's shows that are showing kids that there's men who have emotions. They don't make it, and then some that don't make it a huge part of the show. It's just who they are. They just have emotions. It's not a huge storyline, a huge plot line. It's just men who have emotions, and that's okay. Show moves on. So that's great. So, sorry. Second part of it is our young people. We have our Big Brothers Big Sisters has a national youth council that it's about 20 or so youth from across the country, different agencies who have been a part of the program, who have had this entire Big Brothers Big Sisters journey, and so they work with us to help create these solutions, because we know a solution to youth mental health without youth is going to fall short. So it's important that we have their youth voice and that we can take their lived experience and put that into our programs to make them better. And so a lot of them them are at our Capitol Hill Day and a lot of other events all over the country. And so it's very, promising to see that they're existing right now in a very, unique landscape that is challenging and changing all the time. And so the kids that we see now are already in the community, they're advocating, they're leading, they're making that change in the community, and that's just very inspiring to see.
So there are two things that give me hope. From a professional perspective, we have more data to be more precise. So we have an anonymous reporting system, and we were able to analyze about 18,000 tips from one state in the Southeast. And when we analyzed those tips, we realized that 9% of those tips were related to firearm-related concerns, imminent danger. We also were able to identify the top tip types, which were suicide, cutting and self-harm, harassment, drug use, and bullying and cyberbullying. It gave us information, so as a practitioner, I was able to take those trends and I could see where it came from across the state, and then work with my program team as we're developing interventions that are happening in the classroom to then be more precise about those topics. That's powerful, right? So not to just have data for the purposes of a report, but to have those opportunities for translation that has direct impact on the ground, and then you can study that over time. So that gives me hope as a professional. As a mother, I am grateful and thankful that it is not my generation where it's like, no, just go in your room, you'll be okay, it'll pass. But that we're actually able to have conversations with our young people so that they have the language to express how they're feeling, and more importantly, what would it take to feel better or different. My daughter is a swimmer. She's been swimming since she's 18 months, and now she's on this competitive track for swim. I'm at a swim meet every weekend. But she says, Mommy, when I hop into that water and I lock in, everything that was a weight for me just lifts off. And when I sit there and watch her swim a 500, that's like 20, I am so grateful that she recognizes that part of her feeling well and being well is to lock into that water. And so we are in a moment right now that young people know what are the strategies for me to be better, to feel well, but we have a long way to go because there are many others who don't know that because they don't have trusted adults and they don't have systems and structures that are asking those questions and walking alongside of them to discover those strategies. So those are the two things that give me hope.
Those things, all of the things that you all said give me hope. We do see that trend that you talked about in terms of that decrease of stigma, right, over time. And we're seeing that show up in research too, that there has been a decrease in stigma around mental health and because of mental health literacy. I think it's also safe to say what gives me hope are the people in this room, and I don't mean that in some performative way. I mean literally, you all are making impact, and we're convening together, and we're having these conversations, and we're going away and actually doing something with the information, right? We're doing something with the information, right? Just nod your head and look straight ahead, and you'll, right? And we're leaving here having heard what we heard, but taking an actionable step afterward. And what do I mean by that? That can be simply asking somebody a deeper question than, oh, are you okay? That could be listening before I open my mouth to respond, because I don't have to know all the things. I don't have to tell people what I know. Everybody doesn't have to know what I know. I can just be a listening ear for somebody. And I think the other thing that gives me hope is that there's some research that demonstrates that we have 15 people in our close circle. And our goal with Mental Health First Aid is to train 1 in 15 people everywhere to recognize when someone might need some help and when we can step in. But for me, I hope that you take one moment this week in the upcoming, matter of fact, 24 hours. I'm giving you a deadline. 24 hours, somewhere in the next 24 hours. Can you do something for yourself? Because underneath this whole conversation is a requirement for self-care. We are no good to others. The people in this room are high-achieving humans. I appreciate that about us. But at the same time, we do pour from an empty cup. We do. We say we won't, but we do. And I'm hopeful that as we take care of ourselves, we can continue to take care of our communities, continue to take care of the young people that need us and look to us for direction, but also to help them lead from the front, as so many of us have said, because they're ready, they're already doing it. And I'm just glad to sit back and watch them take over as they're doing right now in this moment, and then also offer that support. But we can't do that unless we're well ourselves.
And that's a perfect way to close out. I see we do have some questions here. Yes.
Hi everyone, my name is Tina Hall, veteran owner of CPR Works. I'd like to have the question presented about creating the mental health first aid training and having it available in all state-supported schools. I referenced it due to the early CPR intervention training that was introduced in 2020 that was championed in also 39 states, including DC, supported the funding. These data was represented in 2025 in PubMed skill retention after school-based CPR training that showed the results of a decrease in childhood mortality and morbidity results. How can we deploy the same strategy using the mental health first aid training course? Thank you.
Wow. Thank you for that lovely question, Tremaine.
Listen, ma'am, love the question. And I think, first of all, I'm going to repeat the question because I think some of us could hear it and others of us couldn't. And so the question I'm going to summarize. You tell me if I did a good job, okay? All right. I'm going to summarize. The question was, how can we do what we've done in schools with CPR training with mental health first aid training, meaning at a state level, ensure that it is supported? I'm like, where does she come from? Love the question. And I think that there's a couple of answers to that. One is there's something called the Mental Health Awareness Training Grants. We advocated for years for that to be a thing. It's been a thing for quite some time. We can advocate for that to continue to be a thing at the federal level. I think at the state level, many states are looking to their departments of education and mandating, and we're advocating, and we have a community of advocates that just are looking to ensure that there's funding available in a sustainable way. And usually that's through the departments of education that say, okay, here's what is necessary. Then there's this other component. What about teacher training? When we go to the school, go to higher education and ensure that teacher training is requiring and advocating for those teacher training spaces to require a certain number of hours for training to be focused on mental health. Now, I would love to say it should be, mental health first aid. Great. How about I don't care? And listen, I still want my job. But I don't care. As long as people are getting access to the information from a mental health literacy perspective, that's what's most important. Now, should it be something that is rigorous? Yes. Should it be enough to actually change people's behavior? Yes. I think advocacy is one way to do that. I think with CPR, what we saw is required for certain roles in organizations. And what we've done is we've partnered with number of associations and certification bodies to say, does this meet the need as it relates to mental health and well-being? Even in the medical community, many medical schools have included mental health first aid as part of that content and curriculum to prepare people to go into the workforce. So, love the question, but also I think all of us have the opportunity to ask the question of how much mental health training is being given in a given space, and then go from there in terms of our advocacy. Thank you for that.
Yes. Next question.
Hi, my name is Jessica Luckett. How is the 988 Suicidal and Crisis Lifeline being presented to the youth in different settings, if at all?
So the last part was, how is it presented to youth?
How is it being presented to the youth in different settings, if at all?
Oh, yes. So I can speak to that. In our agencies, we have a program that was Youth Mental Health First Aid, and so we're part of a grant that's been going on for 3 years now, and so my job and our 20 other instructors in our agency certify program staff that are working on the ground with our youth in the components of allergy and recognizing signs and symptoms of mental health challenges in youth. And so within that training, there's a portion on suicide, and Tremaine might be able to speak more to in detail than I can, but there's a part of it that covers suicide ideation, and so in that place is where we bring up 988 and use that as a resource. We also have a partnership with Crisis Text Line, which is 24/7 text-based mental health support that we give out to youth. Typically, it's very helpful when youth go home because it's on their phones. And so we say, like, when we have our community-based programs, they're like, well, how do I help a youth who leaves the program after the day? And it's like, well, Crisis Text Line, that text-based support can help, and that's where we also push 988. And so we have various avenues and resources and handouts and trainings that incorporate 988, so youth know that resource is available to them.
I just want to add a little bit to what you said about a partnership that both Mitchell's organization and my organization are a part of with Centene in terms of strong youth, strong communities. And there's some folks in the room that are from that program. Hey, y'all. And so one of the things that I think is amazing about that program is it is like a one-day kind of summit where you go into a community with young people and bring young people from across that community and the schools and partner with the schools to give hope and help and information. That's a place where even when it's not like a training program or embedded in the school day, there is an intervention at the community level to support young people and bringing them stories of hope. It's a partnership with the NFL Hall of Fame. It's a partnership that allows individuals to have one day of awareness and impact. What we've seen in being a part of that is not only we tend to think that we have to do a lot to get young people access to information like 988, but it really is making sure that those trusted voices and people that they might admire or look up to are the ones who are delivering that message. It matters who the messenger is when it comes to those messages, and I think that's one place where we have seen that happen, even in a one-day event. There's ongoing engagement after that event within that community, but strong youth, strong communities can't talk enough about how impactful that is as well.
And we have time for one more question, so we'll go here.
Hi, my name is Andrew Gregory. I'm from the American Kidney Fund, and we tend to work with children obviously suffering with kidney disease, so they tend to be isolated due to hospitalizations and missing school or just not finding other kids who are experiencing the same thing as them. We did talk about AI, but we didn't talk as much about social media. And I was wondering if you all could talk about maybe the benefits and the risks of social media for older adolescents.
So social media is one of those things where, again, building literacy around effective use. And so we also have a youth council, and they spend a lot of time talking about how do they help their peers understand how to create positive interactions. We've actually given some examples to young people about what that looks like in the TikTok environment. So is TikTok is still a thing, and Instagram. So for example, right, how do you build public will through social media? Young people are actually creating their own PSAs around content and then flooding through a hashtag to build to mobilize other young people. It's a perfect example of how to leverage social media to drive productivity. So I think one of the things is helping our educators and youth development professionals to be comfortable with leveraging social media for those purposes, to build muscle in young people to be able to create their own PSAs or dances or whatever they do through TikTok and all the things, and leveraging social media that way. I'd also say that this is about building enough literacy in identifying warning signs. We spend a lot of time talking about warning signs through social media and through gaming. So I think there needs to be more of that emphasis so that young people know how to translate appropriately across those platforms.
Thank you so much. And we are at time. I would love to thank Centene, National Minority Equality Forum, our lovely panelists for sharing their expertise today. So if we can give them a round of applause. I would also like everyone in the audience to stay seated for a brief announcement as we have two special guests joining us here on stage, Mr. Daryl Green, who's a Pro Football Hall of Famer, and Amon McFarland, who is an ambassador with Strong Youth and Strong Communities. Let's give them a round of applause and thank them.
And good morning. Can you hear me? Yeah. Can you hear me? Yeah. All right. Well, it's my privileged to be here. I am Darrell Green. I've been in this city for about 40-some years. My wife and I have been married 41 years. She's a DC girl. So all of you are not from here, welcome to Washington, D.C. It's my joy to be here this morning with all of you. I'm also joined on stage by Iman McFarland. Iman is a graduate of UNC, University of North Carolina, where she played basketball, won 3 ACC championships, and 2 Final Fours. She is the CEO of 21st Century Expo Group. And really importantly, as has been mentioned about Strong Youth, Strong Community, she's also one of the longtime members of our Strong Youth, Strong Community team as we travel the nation. She does a great job with both the young women and the men, so it's my joy to be joined by her as well. At this time, I'd like to invite Dr. Puckering to join us up on the stage. Sir, please. As you come, I just want to tell you that I am privileged to be a part of this National Minority Quality Firm Leadership Summit and to be a part of all of you great leaders. Just a little bit that I've heard has just been so extraordinary. You know, I played in the NFL for 20 years. You may not believe that, but a little peanut like me could play 20 years and get one of these jackets. But, you know, I just, you know, football taught me a lot about discipline and teamwork, perseverance, but more importantly, it taught me about real impact, which happens off the field, in my household and in my community, and that's important. And if you'll allow me, I want to just share a little bit about this particular individual. So I'll start by saying it's been over about a decade that I've had the privilege of helping lead Strong Youth, Strong Communities alongside incredible partners, as I mentioned again, Centene Corporation, Pro Football Hall of Fame. This program is focused on giving young people the support, mentorship, and wellness they need to thrive. But what many people do not know is that this work wouldn't exist in the way that it does today without Dr. Gary Puckering, and let me tell you why. It was Dr. Puckering who first brought us together. So I had a vision to do something called Strong Youth. Well, I used to call it myth busting. I called it, let's try to bust the myths that these young people believe about themselves that are not right. Somehow they changed it to Strong Youth, Strong Community, and I'm okay with that. I'm okay with that. But Doc, you remember when Dr. Lacey invited me to introduce me to you, and she told him about, I don't know, 30 or 40 seconds about what I was thinking about. He said, well, wait a minute. Let's have him tell the people. I'm like, what? So I got up on the stage and started to tell the people. And that was what led to the relationships with Centene and others. What we're saying here, as I go back to my notes, is that his commitment to improving community health, especially when it comes to behavioral health and emotional well-being of our young people, has made a lasting difference in communities across this country. His work reflects the very values we try to instill through Strong Youth, Strong Communities: resilience, support, opportunity, and hope. Today we recognize that not just leadership, not just leaders, but a connector, not just a leader, but a connector, a champion, and someone who has helped build something bigger than any one program. It is my honor to present the first ever Strong Youth, Strong Communities Leadership Award, presented by the Pro Football Hall of Fame and the Centene Corporation. Dr. Puckering, on behalf of the young people and communities you've impacted, and all of us who have had the privilege to work alongside of you, we present you this honor. official one right here.
That's right. And she's also a school.
All right.
I'm just going to say this quickly. I played football in college, but not at this level. It was called blindside. I just got hit by a blindside block. I want to thank you so much.
It worked.
It worked.
Thank you for acknowledging that.
What an honor. Darryl Green is a very special person. For those, so I came to D.C. I was a Giant fan, right? I'm confessing all my sins here, right? And came to love then called the Redskins. Darryl Green, one of the fastest human beings in the world, but even more important, what he gave back. And I just have to tell this one story. So he did a program in St. Louis, brought junior high school, I think they were junior high school kids, into an auditorium. The auditorium is packed. And Darryl said, I want everybody who was hit by gun violence to stand up. Every kid in the room stood up. Every kid in the room stood up. And to me, that was the most troubling and disturbing thing I've ever seen in my life, that every kid in that room stood up. And Darryl and his team work with them, and that's what that program has been about. It's been a pleasure to see it grow and the relationship with Centene. So thank you very much. What an honor.
So I got in last.
That's all. So where you want me?
Right here.
Okay.
They say you have.
Oh, you have to grab the picture.
Yeah, that's so no problem.
Hi, I'm Alonzo Mourning, and I want to share an important message with you about APOL1 mediated kidney disease, or AMKD. AMKD is a serious, rapidly progressing form of genetic kidney disease that affects people of African ancestry. Those with AMKD are more likely to need dialysis or a kidney transplant sooner than those with other types of kidney diseases. So it's crucial to detect it early. Visit powerforwardtogether.com to learn more.
Good morning. Good morning. Thank you. Good morning. If we could get settled down, find our seats. This is the panel that's standing between you and lunch, so I would do it. My name is Kellalai Emeru. I lead our Center for Professional Strategic Alliances with Nmqf, and I am super excited for the conversation we're getting ready to have here today. And before we do that, I want you all to look around the room because I find it fascinating. At every summit we have physicians, researchers, health system execs, community health workers. I have a tremendous amount of respect for what you all do and the effort that you bring to this work. And the conversation we're having today will need efforts from everyone to get implemented around the communities that need it most. So with that being said, before I introduce my panelists as well, I want to level set and lay out some facts that are important to this conversation. You've heard it before, but I think it's worth repeating. In the United States, despite spending over $12,000 per person annually, we rank last in terms of access and outcomes among high-income countries. So it's no wonder our summit is themed access, and it ties in very nicely with the conversation we're having. So, hereditary diseases in plain sight is the title of this session, And we know FDA has approved therapies in a number of areas for hereditary conditions that we know disproportionately impacts Blacks and Hispanics. And so the science is here, the advancement, innovation is being made, but we don't have the processes, the structure, and to be able to operationalize it. We know that's the pattern that we see in all of these diseases. So the one thing we wanted to do is not really focus on the science, but how do we make sure the populations that have the highest frequencies for these hereditary disease are identified, are genotyped, and then we'll still worry about the access issue and making sure they're receiving the therapies that they need. So Nmqf is building the answer to that. We're doing our portion. So Dr. Parkran will be talking about our Precision Genomics Initiative, which is an expansion of our cancer stage shifting initiative, which is already on the ground. You've heard him talk about Houston's Fifth Ward, Flint, Michigan, and is really deploying the framework that's identifying the testing across a lot of these domains. So joining me today, we have 4 phenomenal panelists, and their work really sits at the intersection of the genomics that we're talking about, the clinical care, the community, the trust that's needed, and to make sure these communities have what they need. So I'll start with Dr. Kim Smith-Whitley, who's a member of Pfizer medical team and attending physician in Division of Hematology, the former director of Comprehensive Sickle Cell Center at Children's Hospital in Philadelphia, where she has cared for more than 1,000 children living with sickle cell disease. Dr. Smith-Whitley.
Thank you. I think it's really important just to lean into sickle cell and its history with the National Minority Equality Forum, and I am honored to be here today because it is through Dr. Parkran's work that we have increased awareness in sickle cell disease when I was Chief Medical Officer of the Sickle Cell Disease Association of America. He worked side by side with us to make sure we were advancing high-quality clinical care, research, advocacy, and awareness. And I just want to personally thank you.
Thank you. We also have with us Dr. Barbara Harrison, certified genetic counselor, amazing work, clinical assistant professor at Department of Pediatrics, Division of Medical Genetics at Howard University, locally known as HU, College of Medicine. Her work with APOL1, genetic counseling equity, community-centered screening puts her at the heart of what we're getting ready to discuss today, and I've seen her on panels, and thank you for what you do, Barbara. We also have Dr. Timothy Thornton. He's a professor of biostatistics. Woo, God bless you. University of Washington. Senior Director of Statistical Genetics and Machine Learning at Regeneron Pharmaceuticals. His research is focused on genetic discoveries in underrepresented populations, and he's really leading the way at Regeneron. They have an initiative to sequence over 500,000 people of African ancestry for new genetic discoveries. So, Dr. Thornton, thank you. And the man that needs no introduction, fresh coming off of getting an award, actually sitting in for Dr. Akin Baboye, who couldn't be with us today due to some emergency. So thank you for sitting in. Dr. Gary Parkran, founder and CEO of the National Minority Equality Forum, and really the architect behind the Cancer Stage Shifting Initiative and the Precision Genomics Initiative that we'll discuss as well. So thank you all for being here. Without further ado, I'll get into the questions, and I want to start with something that often gets overlooked. The problem begins before patients ever walks into the clinic. Oftentimes, it begins in terms of how we measure and how we classify, how we reference the points that were built around these genetic diseases, genetic testing. So, Dr. Smith-Whitley, if you will, from your perspective, why do high-risk populations remain largely invisible, unidentified, and ungenotyped? If you'd shed some light on that specifically.
I think that with sickle cell disease being the most common inherited disorder of blood in the world, it is even more obvious that individuals with sickle cell disease have been stigmatized. And I think that it is largely associated with the unpredictable pain episodes that these individuals experience and their need to go to emergency room settings to seek care, often involving opioids as analgesics. I also think that it is further marginalized by the communities of color where sickle cell is most represented. And even though 100,000 are living with sickle cell disease here in the US, there are millions living with sickle cell trait. I don't know if any of you in this room have loved ones who have been born after 2006. Anybody have loved ones that have been born after 2006? That means every one of them was tested for sickle cell. And because the testing is done to identify those with disease, you have to have a parent, one that has sickle gene, the other that has a sickle gene or another gene variant, in order to have disease. But every child should know their sickle cell status because they were tested. But because we weren't looking for individuals with sickle cell trait, they were not universally counseled. So I think that this stigma, the challenge of joining testing with good counseling remains an issue in our community today.
Yeah, definitely to bounce off of that. So it's interesting because at Howard, we're actually in an active effort to actually reach those parents whose child was identified with sickle cell trait and offer testing to the parents. And that has really been an eye-opening experience and just really appreciating the lack of knowledge, the gap of knowledge that's out there. I can tell you when we are at screening events and we have our table set up and available to do screening, I have people that just rush by the table. Don't talk to me, don't say anything to me. And if I happen to catch someone, I say, are you aware of sickle cell? Or, if you have sickle cell trait? Oh, no, that's not in my family. And keep running, right? And so I think it goes to that stigma. I think it goes to the just lack of knowledge. The other aspect that I see is, sickle cell disease is still there. It's still a thing. And then, of course, the one we're getting most often now is, there's a cure for that now. Mm-hmm. So we don't need to worry about it. One of the points I want to drive home today is really the power of media, social media, but just media in general, and how it affects our health literacy. Because the news stories of there's a 12-year-old with sickle cell who now is cured, it's powerful. It's a powerful story. And for those for whom it works, it's phenomenal. But let's be very clear that when you really break down the numbers and you find out that, only about 10% of people with sickle cell disease are going to be able to take advantage of gene therapy, there's still that other 90% who's out there who's still looking for an answer, who's still underserved. And that's just the tip of the iceberg. I mean, sickle cell is the obvious example, but I know today we'll get into others as well.
So thank you, Barbara. Just in terms of, you described some of the issues that exist in terms of the stigma and everything. Mm-hmm. Structurally, what needs to change so the right people are being identified?
Yeah, so I think much of that falls on the shoulders of our health professionals. I think we can arm patients, again, through community knowledge efforts, media, and so forth, to be empowered to say something to their providers. But those providers have to also be knowledgeable. They have to be aware of the role of genetics in general in our health, about the tests that are available, clinically available, about the impact that the results of that testing can have on health management decisions, on family planning decisions, even the value of for an individual to understand what was the cause of the condition that I have. We all know today, well, hopefully, we all know today is April 1 Mediated Kidney Disease Awareness Day. We'll talk a bit about that. But one of the important things that I have found in counseling individuals who have this APOL1 mediated kidney disease is the reaction of, it's not my fault. That it was this, there's a lot of information out there about kidney disease, and as it should be, around diet, around weight, around exercise. And these individuals, when they find out that there's an actual genetic root to their disease, especially when you're talking to the young person who is 18, 19, 20, and someone is telling them they have to go on dialysis, you know, the reaction is, what did you do? Or people are looking at them like, what did you do? Why is this your situation? And that power of finding out that, no, it's a genetic cause behind this. You did not do anything, right? We can try to help you now that we know, and that puts us in a more powerful position. But I think it's that, but it was the health professionals to a certain extent who took care of that person who missed those signs, who didn't pick up on that to understand that maybe there was something else going on. So I think that healthcare team is critical.
Thank you. Dr. Thornton, let me bring you into the conversation. What Barbara just described, more of the upstream failure, we also know there's a data problem. The tools we have can predict risk. We're into predictive analytics now that can specify. How do we find these individuals before the crisis happens? And what are some of those tools that can be used with communities in mind? You work in that space, and do you know that we talk about the foundational gap that exists with genomics, specifically with people of African descent. How do we solve that issue?
Great, thanks for that question. I think it's important to note that there's so much we don't know about the genetics of African ancestry individuals. So to date, there have been close to 50 million individuals who've been included in these genetics discovery studies to identify new therapeutic targets, yet 80% have been of European ancestry. And so almost all of these discoveries that we're finding for new therapeutic targets are of European ancestry. And it's important to note that European ancestry individuals only make up 5% of the global population. 2% of the individuals included are of African descent. We make up, African ancestry individuals, around 22% of the population. So it's a huge gap in this discovery. But what's even more problematic is if you look at the genome of an African ancestry individual, African ancestry individuals have about 1 million more genetic variants than European ancestry individuals. So there's many, many more variants that we see in the African ancestry population that you do not see in European ancestry individuals. And so when we're building these tools, and so part of my job at Regeneron the last 5 to 6 years was to develop these tools to predict who's likely to get a disease, but also predict who's likely to respond to a therapeutic based upon their genetic profile. So we're building these models. What are we building these models on? The genomes of European ancestry individuals. And it's not a surprise that when we're building these models based upon the European ancestry genome, they don't do very well in African ancestry population. And on average, what I'm finding is that it's about 25% as accurate, right? So we're misdiagnosing people of African ancestry, and largely because we're not included in these studies. And so to answer your question, how do we close that gap? So one of the ways why I'm here on the stage is I met Dr. Puckering, is that we're trying to start a new initiative that just got started, where we're going to sequence and include in our discovery 500,000 people of African ancestry around the world, including the United States, and we partnered with Meharry Medical College and with Dr. Hildreth. And so we have started this process. We're closing the gap. We're having individuals who are part of these studies donating their blood to be included in the study for new discovery. And so a big gap is the distrust and mistrust. And so I heard a panelist say yesterday that if you don't trust the messenger, you don't trust the message. And so for the launch of this initiative, it's called Together for Change, please look it up. We're just in its infancy. Dr. Hildreth, president and CEO of Meharry Medical College, he was patient number 1. And so he gave his blood and said, this is going to be transformative. And the lines were around the block, people who lined up to be part of these studies to really close that gap. So I think being part of these genetic studies, we need representation. If we don't have representation, these genetic medicines are not going to be as effective for us as they are for the European ancestry individuals that are largely being included in these genetic studies. And so I think that's really important. And so the algorithm is only as good as the data that goes into it. And you see a huge gap in the accuracy of these algorithms by not including people of African ancestry.
Thank you so much. Dr. Parker, we talked about the gaps that exist, but something that's not talked about as often is the human cost. There's a cost, there's a clinical cost, there's a financial cost that talks about a lot, a cost that lands on patients and families, and Barbara talks about counseling families. For many of these conditions, whether we're talking ATTR, APOL1, sickle cell, what are the real world consequences? And I know you bring the historical perspective as well. And so what can you provide in this space? And also, what has led you to do what you're doing in terms of CSSI and wanting to put a framework out there saying a small nonprofit organization can actually do something about it that can be scaled up to the level that it needs to be?
Thank you so much. First of all, before we get farther down the road, Kim has got to talk to you about proteomics. So we're going to put that on our agenda to talk about. So we started working in communities that were exposed to environmental toxins because they had a cancer cluster. Fifth Ward in Houston, Texas, Cancer Alley in Louisiana, Flint, Michigan, water crisis, industrial waste. Our healthcare system has no clinical protocol, has no administrative protocol to address care in those communities, period. Even though the folks in those communities organize themselves to, for example, identify themselves as a cancer cluster. So we're in Houston, Texas. The community comes in and says, the state is certified a cancer cluster. And so we ask, so what does that mean? It doesn't mean anything. You're just a cancer cluster, right? And so we were lucky to be able to partner with Quest Diagnostic, and I want to give them really a big time shout out, and MD Anderson, because they had some screenings that said we can look at blood chemistry, proteins, and predict 5 years before your symptoms, before you have any symptoms for cancer, we can tell that you are going to develop cancer. And the point of that is that the science is taking us further down the natural history of disease before you actually are symptomatic. And so we went into the Fifth Ward, and as a part of a study, we enrolled 214 people in the study in 80 days, and anybody that does clinical trials know that's an amazing thing to happen. People don't line up like that. And we're screening them for 14 different cancers, circulating DNA, basically fragments maybe of the cancer cell, that's DNA that's running around. Alzheimer's disease, because now we have science that says we can look at your blood chemistry and say that you're going to have Alzheimer's 10 years before you're symptomatic. 10 years we'll know if you're going to have Alzheimer's disease. Looking at insulin resistance, because guess what? We can predict the onset of diabetes before you're symptomatic. The point of this conversation is that we also collected genomic data for 7 associated diseases. The real important part of that is if you Fortunately, we're screening for sickle cell, but if you wanted to do it for APOL1, LP(a), ATTRCM, which is the cardiovascular, it's very expensive because you're going into communities and doing what is often called opportunistic screening. You don't know who's got it, and so you're screening people who may or may not have it. Expensive to do. And also the sequencing of it to find out whether they had the particular gene or not. But what the science now has allowed us to do is to do 7 at one time. We could take one individual and do 7 at one time, know if they've got cancer, know if they've got diabetes, know if they're on their way to Alzheimer's disease. You see what I'm talking about? We've now entered into the future because now we're looking at people before they're symptomatic. I'm saying to you, symptomatic medicine is old school. It's old school stuff, right? That's not the future. And so what we're building is the future. So we took that science and we went on to Flint, Michigan, the mayor of Flint. And what we said in Flint, you are the first early detection city in the United States. And we're going to link up your healthcare system with your hospitals. We're going to start screening you because what we want to know is we want to know the onset of disease before you're symptomatic. So when we go in, if you take cancer, for example, everybody heard of a colonoscopy, right? Well, you can't screen a population for colonoscopy. You can't do it. You can't even screen a population for a mammogram. You can't screen a population for lung cancer. But with these blood tests, you can do it. One blood draw, and you've done it, right? And so at the population level, we can go in and see the incidence of these diseases. And then obviously the next step is, so how do we know how to screen them, monitor them, treat them? And so in Flint, that's what we're working on. We're working on now setting up the protocols for communities that have been exposed to environmental toxins who we've ignored. We don't even call them underserved. We just ignore them, right? And now setting in those protocols. I'm excited about that. I was telling Tim about it, and Tim says, wait a minute, we got proteomics. And I'm going to turn it over, let him talk to you a little bit about proteomics and what the science is about proteomics, because what you should understand is we are now talking to you about the 21st century medicine. That's what we're talking to you about here today. And how do we drive this in our community? So, Tim, I'm going to let you talk about it.
Yeah, great. So genomics is looking at germline mutation, what you were born with, right? And so we can sequence your genome. You have 3 billion base pairs. And we're doing a pretty good job for many diseases of looking at your baseline risk, which you were born with. Right? So, but that doesn't tell us anything about your environment, or it can't even tell us when you're likely to get the disease. And so with this new era of omics, in this case, proteomics, so basically, we're looking at what proteins are being circulated in your bloodstream. For example, we're doing proteomics from your blood. We're now building these algorithms to be able to predict when you're going to get a disease, right? And so there's really 2 ways to kind of think of it. It's just one is like baseline risk, when you're likely to get a disease or not, and depending on the disease, it can be accurate or not. We're talking about APOL1 mediated kidney disease. Only about 20%, and this is pretty high still, of individuals who have the APOL1 risk variants actually develop chronic kidney disease. The other 80% don't, okay? And so you have to think about like what is your baseline risk, but then you also have to think about what are some of the environmental factors, but also other genetic factors. There are other genetic modifiers. So there's a whole group of folks who are looking at understanding why some people who have the APOL1 risk variants, they never get chronic kidney disease, right? And so they think there's other genetic risk factors that are modifying it. The proteomics now is really telling us likely when you're going to get the disease or if you have the disease already. So what Gary was talking about is now we're able to kind of develop these algorithms because we have data when we took the proteomic measurements and then we're following them over time, and we're seeing when they get the disease, then we're trying to build these algorithms based upon what we're seeing at time X, and now we're 5 years later, could we have predicted that they actually were going to get the disease? And proteomics is really allowing us to tell which patients are likely to get the disease and when they're going to get this disease. And, you know, one thing that we've been developing, which is really, really interesting, is, you know, there's two types of ages, right? There's the chronological age. That's how old you are in years, right, since you were born. And then there's the biological age. How old are you based upon your biology? So we can really, based on your proteomics, say, hey, you're 50 years old, but your proteomics looks like you're 80. Like, you're close to, you know, your expiration date, for lack of a better word. Term. So we're looking at your biological age, and we're now looking at your proteomic age. And there are some individuals you look at, they're like 50, but the proteomic age is like 30, and they're so resilient. So we're studying them as well, but like, what's going on with them so that their proteomics is looking like so much younger? And so we're looking at both, and if the distance between your proteomic age and biological age is large, we know you're likely going to die pretty early. And we can actually predict pretty accurately, which is crazy to me, how many diseases you have and what types of diseases. And so when we're looking at this database that we're using to develop these algorithms for the proteomics, right, we're actually identifying different types of diseases, and many people have multiple diseases, of course, right? So most people, it's not just one disease, it's many types of cardiovascular disease, and then they have cancers, and so we can actually predict quite accurately, which I thought would not be possible, not only what disease you have, but how many diseases you have, and many of these people in these databases have multiple diseases, and it turns out that some diseases cause other diseases, right? So it's basically a trickling effect where one disease impacts other disease, and so other proteins get turned on if you have a certain disease and causes other diseases. And so we're still at its infancy, but I just want to highlight representation matters. Even when we're building these proteomic signatures, when we're building it based upon European ancestry individuals and we're applying to the African ancestry individuals, they don't do so well. But the flip side of it, when we're building these models based upon African individuals and applying to Europeans, it actually does pretty well. And so this is something I've been harping on for a long time. It's like, you know, you want to study the population that has the most variation, the oldest population, because you find things there and it benefits everyone.
Wow, that's powerful. I mean, just sitting here and just listening to that, knowing that what's not only real, but what has the potential and what's available today is amazing. And if we're honest, in terms of why previous genomic efforts haven't reached the communities that are disproportionately impacted at scale, part of that answer is we just showed up with a cotton swab and didn't really do the prerequisite, the things that are necessary to establish the credibility, to build trust. So with that, I'd like to come to you, Dr. Whitley-Smith, because the trust context, specifically in sickle cell, is very specific and carries a heavy weight. So why is that important, and how are communities who have historically or have a historic reason not to trust the system, how can we build that trust and establish the credibility needed to get them involved?
I think it starts at multiple levels. It starts with the individual and it goes to the community. And I just want to say that for the sickle cell community, which is community of color, they are stellar in clinical research participation. I have some families that have participated in 11 studies by the time their child is 18 years of age. We have families that signed up in the 70s with their newborns and allowed randomization between a placebo sugar pill and penicillin. And those families signed their babies up for those studies. And it's the reason why children with sickle cell disease are surviving now. to 2021, so I'm transitioning to adult-focused care. So I think it is about approach, education, community awareness. I want to say along those lines, when we're thinking about trust, it has to be a transparent conversation. And you have to take the time, to your point, not just to show up with a cotton swab, but to educate that individual what they are being tested for, what it does and doesn't do. And let me just give you a quick example in the sickle cell community. When we first were rolling out this incredible innovation for gene therapy, which is just stellar, individuals were thinking that their germline genes were going to be changed so that they were not going to have the potential to pass on the sickle gene. And it's a somatic therapy. It changes what's in your bone marrow, not what you pass on. So just those conversations are important at every level. The other thing is what tests will and will not do. When you screen, there's something called the sickle dex that I've been trying to get rid of for years. And that is a solubility test. It's really cheap. And you can shake up blood with a particular solution and it can precipitate and it can detect the presence of sickle in many situations. But many situations it does not. And that is what they are using to screen many NC2A athletes. Those athletes walk away thinking, oh, my test was negative. I don't have the possibility of having a child with sickle cell. Does it test for other hemoglobin variants? No. So what disservice have we done by not educating about what the test is, what it can find, if it's genetics, if it's proteins? How are we educating this community so that they are not disturbed by some incredible revelation, 20 years down the line, because we didn't educate them properly?
Thank you so much. And Barbara, this is exactly part of your role in terms of the genetic counseling, and that leads right into the building the trust. Specifically, what happens to families when they receive this variants of unknown significance? I've talked to some physicians who would order some of this genetic test and wouldn't know what to do with some of that information. So how does one interpret it? How do you even talk to them about it into getting them tested? How do you influence one?
Yes, it's definitely a challenge and just feeds into everything that's been said so far about the lack of representation and diversity in our genomic studies, because that's the basis of the test that we order. And so this variant of unknown significance, what it means is you do this germline genetic test, you see one of those thousands of variants that have not been reported before, and you're not sure whether it's actually associated with disease or not. And it's a direct result of not having those populations represented well in our genomic studies. And so on that individual level, maybe this person has overcome their fear of having a genetic test, or have kind of taken that leap of faith to do this test that they may not quite understand. And then the result we get back is this variant of unknown significance, which clinically, we really cannot move on. We can't do anything about it. And the majority of them will actually end up being what we call benign. The majority of them will find out as part of the normal variation that we would have found out about had we had the representation in the database. So that is definitely a hard result to explain. It can erode that general level of not only trust, but just people really feeling like there was a purpose of doing this genetic test. And that conversation, they can spread to their family member. Like, don't bother having it. I had it. They didn't even know what they were talking about once I got my results back. That is the kind of information that spreads like wildfire. And so doing the proper counseling beforehand so people really understand what is the limitation of this test that I'm having is critical to maintaining that trust. us being honest, I am very honest with when I do offer genetic testing to individuals. I tell them from the front, there is a good chance we will get a variant of unknown significance. And this is the reason why. So I'll be very open to you. Now, you participating in this test, the majority of those genetic laboratories will, in a de-identified manner, which also needs to be explained, but we'll share that information into a larger database so that that can contribute to our knowledge down the line. And so, in some ways, I tell people on some level, even clinical genetic testing is a research project. Like, it really is, and we have to be honest about that. But I think that goes into building that trust of just being honest about what we know, what we don't know, that even that we may find this genetic cause, but there's still those environmental factors that are a part of it. And I want to add, as we think about proteomics and we think about this next level, because there's definitely levels to this, right? So that next level of genetic testing and studying our kind of biologics to make predictions of the importance of engaging the community in those conversations. And I think gentlemen up here are a great example of that, because you're going to need those spiritual advisors. You are going to run into those individuals that say, you can't tell me what's going to happen in the future, right? Because I come from a spiritual place and I know who's in control. And that is true. Right? And there are ways to have those conversations and have people appreciate the wealth of knowledge that the good Lord has provided us with, right? To be able to use that to impact our health and take better care of our temple, right, that we have been given. And so those conversations are important. And I know you have interacted likely with our faith-based genomic initiatives that are out there. I know one led by Tashaka Cunningham, who is doing that hard work of engaging all of our community. Because again, the more multifaceted place that we get that message in, again, whether it's through media, through our spiritual places, through our education, all these places, all that's going to add up for people to feel more comfortable and feel more trustworthy and have those individuals at the table when that research is being done. Not just going to them once you have results and you want to share it with folks or you want people to participate in a study. No, have them at the table from day one when you're developing those projects. Because that also is going to bring the community's concerns to the table, make sure that they are identified and dealt with as you're doing that research.
And Barbara, that reminds me of something that I should have mentioned. I think that, particularly for this audience, we really need to advocate for good genetic counseling. Because things can be revealed in genetic counseling that are quite personable and can shake families up. And even testing for sickle cell disease and sickle cell trait, there have been questions about paternity. So they are really important things to have private conversations about when you deliver this information and when you don't, and how you deliver it. So we really need to also think about compassionate, respectful counseling when these results come back.
Yeah, absolutely. And being open-minded to what is best for that family. Because one option that's good for one family, one individual is totally different. It's the same clinical situation, but I'm talking to two different people and they make two drastically different decisions around testing or how to share or when to share those results. So yes, I thank you for the shout out.
Thank you both. I think information is knowledge, and from knowledge, you can have the wisdom to decide and make an informed decision in all of what we're talking about. And I think you reminded me, the good book says, my people are destroyed for the lack of knowledge. I can't quote exactly where it says that, but I know the good book does. Thank you. So how do we go from having the technology, addressing the gap, to do you believe, can we make this a reality at someday we know where these high-risk population is and we can make that part of the standard of care? What NMQF is doing and to be able to put that at a level of scale where it can become the standard of care for people that you're talking about, Dr. Puckering, in terms of being environmentally exposed. We know that social drivers of health plays an important role. So there's the pharmacogenetic as well, the nature versus nurture. How do we make that into where it needs to be today?
So I'm going to answer that question by linking the conversations that you've been having yesterday and today. So what you've been hearing is that we're disenrolling people in Medicaid. What you've been hearing is that we're cutting out premium support for the marketplace. What you heard last night were the leaders of the health department for the DMV saying that they're going to lose hundreds of thousands of people are not going to have access to health care. Basic health care, right? And now we're sitting here talking to you about the future and what we are actually capable of doing, right? And you got members of Congress up there sitting down, giving tax cuts to each other, right? And saying, oh my God, I can't pay for your health care, even though every American household contributed $4.5 trillion into the kitty. That's the number. $4.5 trillion is what comes out of every American household every year, but we can't afford you, right? This comes down to advocacy. This comes down to understanding what we are capable of doing and what we want that future to look like. I sit with companies on the early detection side, and I marvel at what they're about to do, right? We can look at type 1 diabetes and predict whether you got it or not. Alzheimer's, Parkinson's, cancer. It's only the beginning. But we're spending our day talking about Medicare rescissions, throwing people out of basic health care. That's the future that's being offered up. And excuse me, we voted for that. We are a democracy. There was a vote. Did I miss it? I think there was a vote. Right? I think people were told what was going to happen when you vote that way. I don't know, that's what I heard. Right? So I'm not blaming them. We gave them permission. We got to put it where it belongs. We got to call a thing, right? So we can sit here and paint the future for you, tell you what it's going to look like, but then you can go home and vote any damn way you want to. But don't complain. Don't complain, right? So at NMQF, we're going down to the community level. I'm just going to tell you one thing we're doing in Flint, Michigan, that it's an experiment. Sometimes I tell staff, we go roll the dice, we're going to go roll the dice. We're calling it a Community Innovation Expo. So we're asking all of these innovative companies to join us in Flint on August the 15th. Think about it like a car show, right? Americans like to go to car shows, see what the new car looks like. We can do that in medicine. We can go into a community that is being exposed. In Flint, Michigan, 50% of the population have experienced cancer deaths. That's what it looks like. And we're saying, we're going to bring you the science so that, guess what, we can see your cancer 5 years before you're symptomatic, and your kids and your grandparents won't necessarily have to die from that, right? Because we have to educate the American consumer. What our healthcare system has been very good at doing is dampening that community voice so it doesn't get into CMS. It doesn't get into our Medicare and Medicaid programs. It doesn't get into our insurers to say, here's what we're spending our $4.5 trillion on, and here's what we want to get out of it. Right? But the only way to do that is to take someone like Tim into the community, and they're going to hear the first word, they're going to have proteomics. What the heck is proteomics? Right? Don't sound like a rap song to me, right? But it is their life. I'm going to stop just one point because it's incredibly important. Our bodies run on a set of rules. Tim is talking about proteomics, talking about sickle cell, we're talking about risk. We don't control those rules. The president doesn't control it, Putin doesn't control it, the King of England doesn't control it. It is God's gift to us, right? So we can ignore those rules every day we want to, because that's the other blessing he gave. He said, if you're stupid enough to go on. But you will get punished. You will get punished, right? And so we have to help people understand those rules. There are fundamental rules, and our legislators have to follow those rules too. For heads of departments of health to sit here and tell you they're going to kick 100,000 people off of the healthcare system, when people sit here and tell you they're going to close down rural hospitals, what do you think is about to happen to those people? The rules are going to kick in. They don't care. The rules are going to kick in. So our sense is policy is a branch of medicine. If you ain't advocating, you ain't getting. And so part of what you need to walk away from here is understand the science. It's fabulous. We got a lot of companies in here, I can name them, doing spectacular things in here. Just fabulous, right? But they can't get it to the community. They can't. Because our government said they don't want to pay for it. They said they don't want to pay for it. But we are our government. I'm done.
Thank you. Thank you. It's actually a really nice way to summarize it. We talked about the science is here. Some of these therapies are already approved. We talked about the data capabilities existing currently today. And it'll be a shame if we're still talking about the structural systemic issues at Nmqf Summit 2029. You know, I don't want to do that. I want to allow the audience opportunity to ask questions. We're going to have just maybe 5 minutes for Q&A. There are mics in the back of the rooms, if you will, please. See one brave soul standing up.
I don't think there's a mic back there.
There's one on each end. There you go.
Nobody else with a microphone? I heard you talking about proteomics and gene therapy, and you can turn, I wanted to ask one question about, can you turn your disease around, first of all? And then that passage of scripture, Hosea chapter 4, verse 6, first of all.
I appreciate it. Thank you.
How do we get people tested to say, look at this, are you ready to leave your family? What are you willing to do to change that? And also, Dr. Putnam raised the question or raised a statement about 50% of people in Flint are dying of cancer. And I wrote a note down, it's good to see the cancer coming and prepare people for care before sickness comes. But let's see why it's coming. How do we see why the cancer is coming? Or are we just interested in health care and not health cure?
Yeah, these are great questions. And so from the proteomic side and even the genomic side, I would say we're still in the infancy of really understanding the causes of disease. And so, you know, I never thought I'd be working for Big Pharma. I mean, I was in academia for 14 years, and then there was an opportunity to be part of this new initiative to grow and expand the diversity of our genomic databases for new therapeutic discoveries, so I jumped on it. It's important to note that, you know, we are developing these therapeutics based upon genetic evidence. Regeneron has 14 genomic medicines in the clinic right now that we're pursuing. You might have heard the new FDA-approved drug for gene therapy for congenital deafness, right? So these kids are being born deaf. They're doing gene editing of the OTOF gene, inserting appropriate gene that's now working. So now these kids can now hear. I mean, it's amazing. But in any field that I've seen, genomics and genomic medicine representation matters so much. Even the gene editing, some of these gene guide RNAs to find where to edit, what population do you think it was editing the wrong gene the most? What genomes? The African ancestry genomes. So even these guide RNAs that are targeting where to edit the gene, off-target gene editing was the highest in people with African ancestry because the database that was being used for gene editing and developing these guide RNAs were primarily of European ancestry individuals. And so they had to go back to the drawing board and get better representation to improve the accuracy of where you target the correct location of these genes. And so to answer your question a little bit more clearly is that we're still in the infancy. So early detection is key. So from our perspective, if we know someone is likely to develop, you know, diabetes based on the proteomics 5 years from now, we can start the targeted treatment early. And I think there's no substitute for finding something early. Alzheimer's disease, diabetes, and like I said, we're doing this across a broad variety of disease and clinical outcomes. And so there are some for which, you know, we can start targeting. And, you know, like I said, if you're talking about cancers, you know, you catch things in stage 1. I think Dr. Perkin was saying stage 1 cancers, many of them, you catch it early, 90% success rate after five years of being alive, right? So early detection, I think, is pretty key. But the turning it around, it depends on the disease. But I think in every situation, early detection is an advantage, and that is the future, and I think this is what proteomics can offer us.
And I'm going to add, because with sickle cell, we do have some experience now. And I can say that once you have a complication, it's very difficult to reverse it. And one of the challenges in our sickle cell community right now is that individuals living with sickle cell disease who have gotten some of these therapies are hard pressed to get some of their medical issues covered because the healthcare system thinks they should be gone. So we have to think about how we use words like cure, right? And I think to your point, we need to also understand that when we apply these therapies, that it's not one size fits all, right? And that genes work not only independently, but with each other. And we know in the sickle cell community right now that there's another gene that is making some of these therapies more risky. So staying, I think, to Tim's point, engaged, educated, making sure that we have access, right, is key, and making sure that we participate in these studies so that we can better understand the genomics as they apply to communities of color.
Just why the 50% in Flint?
Oh, yes. So how do we see that punch coming?
No, the answer is we don't know. We don't know how disease forms at the cellular level, and that's really, we will know at some point, but we just don't have the answer right now. I think it's a safe answer.
There's a lot of correlation. There's no, I mean, it's hard to prove the causation, but a lot is being looked at. One more.
Yes, hello. My name is James Jones. I'm with the National Forum for Heart Disease and Stroke Prevention. At the risk of asking a very similar question, I had to come up with something else on the spot. I will say I'm a big fan of the body knowledge on the stage and a big fan of the body knowledge in this room. I also am a big fan of wisdom, which is how we use the knowledge we have. So my question is, how do we ensure that using proteomics or genomics or blood testing to predict the onset of disease doesn't become condemnation for the patient and or community, but turns into conviction to get either healthcare to move, municipal government to move, communities to move? How do we ensure it's not condemnation but conviction?
I can start. I think you're bringing up a really good point. I think that one of the difficulties is context. And we know that there are going to be issues that we have to advocate for because some people with certain genetic results are going to have a hard time finding healthcare insurance in the future, right? So we, to your point, must make sure that we're also informing our communities about what their rights are and to make sure we're paving the way to advocate for those that have the genes that say you should not have this condition if you've done X, is not being accused of doing X and not getting covered in appropriate health care. And I think to your point, we're going to have to continue to advocate, make sure our communities are knowledgeable and know what their rights are.
Just to add, I think it also brings forth this point of policy being part of medicine. So, you know, it took about 13 years to get the Genetic Information Non-Discrimination Act passed. And that was an act that protects people who get predictive genetic information from being, you know, dropped or not being able to get health insurance. It doesn't protect against disability and long-term insurance. So, you know, that's part of the conversation we have before people do this type of predictive testing. Because as much great information as can give you about your health, and we may be able to manage your health better, there's also this downside that people need to be aware of, and again, make that informed decision. I think the other thing I'm just really motivated to just say something about, and this, you know, is something we always have to keep in mind, is eugenics. When we start talking about identifying certain traits and things as being positive or negative, I think it's, you know, it's relatively clear when you talk about heart disease or cancer, right, or even Alzheimer's. You know, you start talking about deafness, you start talking about people of short stature, you start talking about people with certain levels of intelligence, right? Like those start to get very gray. And the more we learn about our genetics and learn about the role of genetics in those types of traits, we as a community, all of us in here, and in our respective ones, need to be very astute and aware of that, and ensuring that people from those disability communities are at the table when we're having these conversations and not just leaving them out. And ensuring that there's not now going to be this social expectation that if you know, even something like sickle cell, that you're not going to have children. You know, is that really what the decision we want people to make, or have that expectation to be there? For some, it might be the decision they want to make, but for others, it may not. And so it's still important that we focus on good treatments, on transformative therapies, on doing that type of research, as well as talking about early detection, some even, verging on prevention, but really understanding where that conversation can take us. And so I think it's just important for us to acknowledge that.
Thank you so much, Barbara. I think that's a really powerful note to end on. I want to thank all my panelists and thank you all, the audience, for participating. I think lunch is the next program, so. Oh, yes, we're going to.
Good afternoon. Oh, it's not on. Oh. Good afternoon. Good afternoon. Hello, everyone. Hey. Hello, everyone. Good afternoon, and welcome to the Booker T. Washington Awards Luncheon. It's a pleasure to join the National Minority Equality Forum in celebrating the visionary leaders who are advancing health equity today and each and every day. My name is Michael Frazier, and I serve as Legislative Counsel for Congresswoman Eleanor Holmes Norton, DC's very own. And I have the privilege of spearheading her healthcare portfolio. I'm also proud to be recognized as one of Nmqf's 40 Under 40 this year, alongside leaders in healthcare, law, research, and policy. And if there are any of the 40 Under 40 folks here, just shouting you out, raise your hand, stand up. Yeah. But today, right now, we are here for the Booker T. Washington Awards. The Booker T. Washington Awards recognizes an individual or organization that has made an outstanding contribution to the promotion of wellness in emerging populations. Booker T. Washington started the National Negro Health Week in 1915 to promote wellness in Black Americans. From 1921 to 1953, the National Negro Health Week was a program supported by the Public Health Service. By partnering with Congress and the White House 45 years later, Nmqf started National Minority Health Month in 1998 as a successor of the National Negro Health Week. And with that, I will be introducing the CEO, president, and someone who I'm going to adopt as a mentor, Dr. Gary Puckering.
I'm always so proud of our 40 Under 40. We have 440 of them around the country. We'll talk about that later this evening, but another distinguished member of that 40 Under 40 group. I hope everyone has been enjoying the conference. I have been learning tremendously from the presentations and actually from the conversations that have been in the hallway out there. My task this luncheon is really to start off by saying some thank yous. It reminds me of when the war in Ukraine started, and they had these U.S. commentators looking at the Russian forces as they were on their way to Ukraine, and they were laughing. And they were laughing because they said, it's all about logistics. And when we look at their logistics, we know that they ain't winning anything because any good commander knows it's about logistics. And here, I'm here to thank people that allow us to have some logistics. These are sponsors that have made the Nmqf work possible. All of the things that we talk about and work on is only possible because of the sponsors who support us and go into a community. And certainly this event here, we have some sponsors that I want to recognize. So our Platinum Plus sponsors are Blue Cross Blue Shield and the Centene Corporation. And I want to thank them. We work collaboratively all year long, and I want to thank them for their sponsorship for the summit. Our Platinum sponsors are so Amazon, Amgen, Bristol Myers Squibb, Genentech, Gilead, Merck, Johnson & Johnson, Pharma, Sanofi, and Vertex. And I want to thank them so much for their support. Gold sponsors are the American Kidney Fund, the American Medical Association, Hologic, and Lilly, and finally, our silver sponsor silver sponsor is Biogen. I'd like to give all a thank you for all of their great support. With that said,
Okay. Good afternoon, everyone. Thank you for being here. My name is Munira Bangi, and I lead the Center for Sustainable Healthcare Quality and Equity at the Nmqf. That's the SHC team. And our work is rooted in the community. So we work with our Faith Health Alliance, our barbershops, our nail salons. And so I have the distinct honor of introducing my wonderful team. We have Leslie Zuniga and Chini Upusuku and Laura Lee Hall.
I barely need a mic, huh? I wrote some notes because I wanted to be clear about what we're celebrating today. So excuse me for doing a little reading. We're actually giving our SHC Champion Award to 3 individuals representing 3 institutions. We've worked with them for a number of years. See, that's what it's like with us. You work with us once, you keep working with us. They have successfully implemented quality improvement program. We call ours DRIVE, which started 8 years ago with Santa Fe support. I think DRIVE is noteworthy because it focuses on health equity and community engagement as core measures of quality, which the rest of the quality world has been slow to come to. We've literally reached hundreds of clinicians and thousands, hundreds of thousands of patients. I'm proud of this work. You will note that the individuals and institutions, the individuals receiving the award are largely not clinicians this year. Actually, they're administrative folks. You know that tired phrase, it takes a village? These are folks who can really change things and make things happen. So without, I want to say also that while we are very happy that we have partnered with huge health systems, these 3 systems alone are responsible for our QI program on flu vaccination and delivering 50,000 vaccines, which is a 22% increase from previous years. So let me tell you who these individuals are, because it takes a system, love those big systems, but it really takes a champion to move those big systems. So right now, I'm going to introduce Mr. Samuel Park. He's not here today. He's the Vice President of Ancillary Services at the Southeast Medical Group, SEMG, as it is lovingly called, is one of the largest independent primary care and multi-specialty medical groups in the Southeast, with operations in Georgia, Alabama, and Tennessee. I also want to acknowledge Dewanzia Sutton, who also is not here, from Our Care. I guess they don't really let these people out of the office, huh? She's a clinical pharmacist who works in Oxford, Mississippi. And Our Care is a health system serving communities across Arkansas, Kentucky, and Mississippi. So funders, if you're interested in reaching some of these communities, come see us. Our 3rd champion and award winner, Michelle Lamb, who I believe is here. Where is she? Hi, Michelle. So she's with the NYC Health and Hospitals Elmhurst, and is administrator for the ambulatory care services. Okay, so this is like one of, if not the largest systems in the country, in Queens, New York. And there's a little diversity in Queens, I'm told. So she really supports process improvement. Doesn't seem like a glamorous term, but man, are you a glamorous, wonderful person. Congratulations, Michelle. You'll have to wait for it, but we have a 40 under 40, a winner also from Elmhurst. We have worked with them for a number of years. So glad to do that. I'm not supposed to give a talk, but I'm going to say a couple things. I already told you about how we've had increases in flu vaccination rates. There have been other things these places have achieved. You've already met Chinny, Leslie, and Munera, and I'm so proud and humble to work with them. Can we give it up for them? I want to acknowledge members of the Faith Health Alliance in this room. Raise your hand wildly. They are making it happen in the community, I'm telling you. I really want to express my deep gratitude to Dr. Puckrin. I don't know, where is he? Hi, Gary. Well, he brought me in 8 years ago, 8 years. And we started SHC in the Drive program. It's been a great honor. Thank you, sir. And I guess I want to thank everybody in this room. A lot of us are not newbies. We might even be old-timers, some of us, huh? It has been the blessing and honor of my life to work with all of you. Save my husband. He's over here if you want to clap for him. And my 2 children and the good Lord above. Thank you for everything you do.
Good afternoon. Good afternoon. My name is Gretchen Wortman. I'm Vice President for Policy and Program of the National Minority Equality Forum, and in that role, I am Director of the Center for Public Policy. I have standing with me here today Dr. Britt Weinstock, who is the Director of Federal and State Policy for the Center for Public Policy, and I have another staff person who could not be with us today because she's home with her new child, Attorney Keiko Purnell. We also are here this afternoon to honor 2 awardees who are part of that team of policy leaders in patient advocacy who I think are rarely seen and generally not heard from. One is, excuse me, Ms. Courtney Foy, who is lead for public affairs for Sanofi. She couldn't be with us today. The other could be with us today, and it's Dr. Alyssa Schatz, who is Vice President for Policy and Advocacy for the National Comprehensive Cancer Network. We are conveying to those 2 individuals our Leadership in Policy, Equity, and Advocacy Awards for 2026. Alyssa.
Oh, I think you lost it. Thank you so much. Hi, I just want to say thank you so much. It really is an incredible honor and a privilege to get to work with the truly incomparable Gretchen Wortman and Britt and our colleagues at ACS CAN, Angela Saylor and James Williams, who together convened the Alliance for Cancer Care Equity. So just really grateful to be able to work with them, and also just want to say what an honor and privilege it is to get to learn from NMQF. You all have been doing this incredible work, really moving mountains for nearly 3 decades, and you have this great success and result in meaningful change because of how you excel at partnership. And so I just really appreciate the opportunity to be a tiny little piece of the monumental work that you all do. So thank you so much.
Good afternoon. My name is Kalalai Emru. I lead our Center for Professional Strategic Alliances, Nmqf. I have Michael DeSalvo Solarte, who's a program manager. We are still a team of 2, a small but mighty team. So we serve as a hub for professional groups. We undertake many initiatives working across various disease states. And every year we like to recognize a team whose vision, support, and expertise really help us shape our priorities, allow us to do the work that we do to accomplish the mission and vision of the larger organization. This year's award is going to our delegates and Alan Ryan, the Senior Director for Advocacy. Please join us on stage, and please join me in celebrating excellence in kidney care. Our partnership and collaboration with this organization goes beyond an initiative. When you work with people that get the issue, that understand the dynamics on the ground, but also go above and beyond to really be about patients and center everything around the patient, it makes everything work well. So thank you. Thank you, Alan. Appreciate it. Yeah. Yes, okay. I'll hold it. Okay. I'm the awardee, huh? Right.
Thank you. So I'm giving you an official.
Okay, all right. Thank you. You don't want to say anything?
Sure.
Sure.
I would just like to say we are very proud and pleased to be working and partnering with this organization. We have a long relationship with the National Minority Equality Forum and truly value the work that this organization does and leads on behalf of patients. So thank you very much.
Thank you. That'll be easier.
All right, good afternoon, folks. Brandon Garrett, you may have seen me up here a couple of times. Thank you so much for coming to this summit and being a full participant in it. I'm going to take a point of personal privilege and also introduce some of the folks on our operations team to make things a little easier for Gary later. And so Cecilia Masters, want to call on up? They didn't know, so that's why I have to bring them up. Raven, Margaret. Sharon Thomas. And last but certainly not least, the longest serving person at NMQF has been here since the very beginning and made sure that we got paid and everything goes right, Margot Payne. You gonna give up? So a we'll let Miss Margot come on up, but I just want to, to save a little time, I'm just going to start speaking about our Outstanding Corporate Leader Award winner. One thing that we do at Nmqf when you all work with is we're the corporate roundtables. This is a group of leaders from organizations. It could be for-profit, nonprofit, big company, little company, whatnot. But they all come in and they help us to determine. Come on in. You guys want to see them more than me, so you could put the camera on them and I'll just voice of Brandon in the background. But nonetheless, they all come together. We meet all the time. We talk about health issues. We say how we can work better together, what we can do. And one person in particular, at least over the last 2 or 3 years since she's joined Johnson & Johnson, has really been effective and come through in a way that not many others can. If I call on Ashley Sofer to do just about anything to move the needle, she's going to do it. I think it's because, one, she started off in Illinois. She went to Miami of Ohio, and then she got her graduate degree from Harvard in education, right? And then she did 6 years in the public school system in and around Chicago, both urban and suburban. And then she worked in the STEM Connector program in external affairs, and then she brought her talents to Johnson & Johnson's and eventually brought those same talents to us. So we want to, with everybody that supports us at Nmqf, whether it be through the grants program, through the work in Flint, through the everyday work we do thank our corporate roundtable, but we in particular want to thank Ashley Sofer for all her work. So Ashley, please come up. Do you want to say anything, Ashley? You don't have to.
Brandon told me I didn't have to say anything, so I wasn't prepared to do so. But specifically, I always say that my job is basically getting to make friends for Johnson & Johnson, which makes me the luckiest person on the face of the earth. And getting to make friends like Nmqf has been absolutely incredible. So just thank you to Brandon and Gary and Gretchen and the whole team at Nmqf for everything you guys continue to do and all of the work I know we're going to keep doing together. And I just really appreciate this recognition. Thank you.
And I'll bring you.
All right.
Okay. That's fine.
Hello. We're one of the last, but not the least. I'm welcome to the Center for Communications and Public Affairs team. If you've seen us around, we probably look frazzled because communications, of course, supports everything at Nmqf. I'm really proud of this team. I'm Adwa Chemating, Vice President of Public Affairs and Communications, leading the Center for Comms. And here is Taylor R. Lopez, our Health Communications Director. And then we have Victor Mejia Lacayo, our Marketing Director. We have Jessica Wilson, our Social Media Associate. We have Subhash Kafli, our Digital Marketing Associate. And then we have our glue that holds us together, Dane White, our Internal Communications Manager. Thank you for that. You know, we're really excited that for this summit, we're debuting a new award, the Lift Every Voice Patient Empowerment Award. In all that we do, it's really important that we don't forget the patients themselves. And we're really excited that our Lift Every Voice program does provide a voice for patients directly to communicate their lived experience. And so the Lift Every Voice Patient Empowerment Award recognizes individuals who have transformed their lived experience into leadership, who've become advocates for other patients, and step into really sometimes uncomfortable spaces and positions
to take on the challenge to educate and uplift others navigating complex health journeys. At this point, I would like to introduce Taylor, who leads our Lift Every Voice program, to recognize our awardees today.
Good afternoon, everyone. It is my honor to introduce our Lift Every Voice Award recipient, Juanita Miller. Come on up, Juanita. Juanita is more than a metastatic breast cancer patient. She's powerful, she's an advocate, she's a storyteller, and a source for strength for so many navigating similar journeys. Juanita, your courage, your vulnerability, and your commitment to others inspire us all, and it is really a privilege to recognize you today. Thank you. Oh.
We have one more awardee. Yes.
Okay, we have one more awardee for our Lift Every Voice Award, and I would like to now recognize Doretha Burrell. Doretha represents the very heart of patient advocacy, grounded in compassion, resilience, and in an unwavering dedication to helping others also who are navigating their own breast cancer journeys. It is a privilege to recognize you today, Doretha.
Thank you so much.
Thank you.
Thank you.
Thank you. All right, come on now.
That concludes our awardees today. We did have one award for Jaquanda Johnson for our For Your Health News program, but she could not make it. Flight got canceled all the way from Flint, Michigan. But we hope that we can send her an award at a later date. Thank you so much.
Hello. So I'm going to ask Leo Zhu and Christina Edwards to join me. They're part of our Center for Clinical and Social Research. So I think you've heard that Nmqf, we actually do clinical research. We publish in major journals all over the country. Leo is our statistician and principal statistician, and she's published in some of the most prestigious journals, both internationally and nationally. And Christina is our clinical director, managing our clinical studies. We have 2 ongoing right now in Flint and in Houston, Texas. And they've done fabulous work for us. I'm so pleased to have them as part of the Nmqf team. So part of what I hope you've come to understand is that Nmqf is divided up into various centers, and the presenters this afternoon have been the leaders of those various centers. I now have the privilege to talk about the Booker T. Washington Awards, and we have 2 of them today. One of them is for Melissa Bishop Murphy from Pfizer. I've known Melissa, I think forever. She is part of the warrior class. When I'm thinking public policy and I need to get some advice, I call Melissa. She knows everybody. She's been in every fight imaginable, fighting for patients. I would not think about going into battle without a conversation with Melissa. And she's worked and understands both sides of the agenda and understands deeply what's happening in community. One of the things you value is somebody who will tell you the truth, and Melissa will tell it to you whether you like it or not. And I value that so much, and have had a chance, as I said, worked with her for years. She was part of the early start of Nmqf and has always given us deep advice. I understand she cannot be with us today, and Renika, please, Renika, if you'll come up and accept the award for, oh, there you go, good. Thank you so much. And tell her I'm holding it against her. Come, you want to do over here? Here, come. Oh, your award.
Good afternoon. So as Dr. Puckering said, I am not Melissa Bishop Murphy, but what an honor to stand in her shoes today. She is a longtime equity pioneer with Pfizer, double-digit years leading our multicultural health equity collective, building this relationship with the National Minority Quality Forum and keeping them top of mind in our organization, making sure that I was able to be here today to continue to facilitate this relationship and really connecting with those communities that we know are disparately impacted by so many things. She is making the change. She is building community inside of our organization so that we can make that change that we need to make and not be the big pharma that people think we are, but be the big pharma that we know we are with individuals like Melissa, myself, and many of our team. So thank you so much. It's an honor to be here to fill her shoes. Thanks.
Our next awardee, sometimes you get an opportunity to learn and an opportunity to do what you would think was unimaginable. And our next awardee went on that journey with us, and here I'm talking about work that we were doing in Houston, Texas, which was a cancer cluster. We had been doing work with Quest Diagnostic. We'd actually been doing a 5-year study on COVID in 5 communities around the country. It was a 5-year study. And when we started to think about our cancer stage shifting initiative, we reached out to Quest and asked them if they would essentially become our phlebotomists to collect the blood, because in conversations with them and MD Anderson, they were just starting work on some algorithms that they thought would predict whether someone but screen people for cancer maybe 5 years before they were actually symptomatic. And Julia Larson came to into Houston, into the 5th Ward in Houston with us. It was pretty dramatic. They had just done a film on cancer in that community that was pretty stunning. We'll send around the link for that study. But we also were able to do a town hall in which the communities came out and talked about the community experience, their personal experience with cancer. It was tough stuff, to be honest with you, when you listen to, and it wasn't just the cancer, it was the disappointment. At every level of society, they were being disappointed. They thought that their land that they were on had had a creosote deposit, chemical deposit from an industrial accident, and they thought that the city, the government was going to come in and essentially buy the land and sort of rescue them, and ended up disappointed on every scale. And so it was instructive to be in the community and learn, but it was also instructive to Nmqf because what Quest allowed us to do was to collect those samples, not just for the cancer, but then we started to understand there were tests for Alzheimer's and there were tests for diabetes, and it opened up the whole world of multi-disease screenings, where you could, at the population level, at scale level, you could go in and you could get a sense of the incidence of disease at a population level. And it was at that moment that I knew I was entering, I'd gone through the wormhole. I was in another age. And Quest allowed me to go on that journey. And Julia was really the pilot that sort of guided us along, and we had a chance to talk with senior staff and learn so much about what all of this new science and capabilities are. And I felt like I'd gone back to graduate school and was learning a whole new discipline and learning, and Julia has been just a remarkable person, and this award is not even the appropriate thank you for that experience. So Julia Larson, please, from Quest Diagnostics. And while she's coming out, I'm just going to say this out loud to everybody in the room. What I just said, you should remember for a lifetime, because you just went through that wormhole with me. And you may not know it, but you just went through that wormhole with me. So thank you. Julia. Thank you. We're going to ship people in.
So I think all of you appreciate in this room just the vision that Nmqf, Dr. Puckrin has on where we're going with healthcare is extraordinary. We're just honored and privileged to be on that journey with them, and we look forward to the future. So on behalf of Quest, we thank you from the bottom of our heart.
I have one final presentation to make. This is for a person that I've been working with for about 23 years, who have been down in the trenches doing fights. I'm going to tell one story. She didn't even know we're giving her this gift, but the minute I start telling the story, she's going to know that I'm speaking about her. It was a drug called Vital. It was for African Americans with heart failure. reduced mortality by 43%, reduced first-time hospitalizations by 34%. African Americans, if I'm remembering the numbers correctly, had something like 50, 60% hospitalization rates over whites for heart failure. This drug passed the clinical trials, it was just good science. And Gretchen knows the story as well as I do. So we get a call one day, we're in Chicago. I'm not going to tell you the name of the organization that called us, payers. And they said, we ain't paying for it. Out of nowhere, we ain't paying for it. So, we go to CMS, to the administrator of CMS. He said, we ain't paying for it. So, us, we got a backup, and we started to put together, what back in those days were called performance measures, to actually build the science so that it would essentially be part of a quality program to make sure that African Americans with heart failure got the medication. We did everything, to the letter. And so we go in the meeting the day we're supposed to get confirmation that we had done what we're supposed to do. You know what they said? We changed the rules. Oh, you talk about how many jelly beans are in a jar? That's what that was like, right? And what we knew, that 8,000 African Americans were going to die every year because they were not going to get the medication. That's a fact. There's a record. And I'm not even going to call the name of the organization. It was a medical organization. And you know why they decided that they were not going to support the medication? They said because black people couldn't afford it. In writing. Oh yeah, in writing. In writing. Wrote it down. Sent it forward. Oh yes, indeedy. So Gretchen Wortman and I have been in those kinds of fights. Alan knows what I'm talking about. We talk about ESRD. And what's going on in that program? So I just want you to know that deep in the bowels of the system, there are decisions made that impact the lives, not just of African Americans, but those people you call underserved, structured. And it's all done very nicely and friendly, everybody's everybody, right? But we are undeterred. So some of the work that Gretchen has done is she's led the writing of ICD-10 codes. For those who don't know, that's how physicians get paid. Nmqf, through Gretchen, have written those codes. Deep in the system, trying to understand how do we make sure that our community gets. So the BRCA1 gene, the ICD-10 code for the BRCA1 gene, Nmqf, Gretchen, pulled together the medical societies and got them to approve that. Went through all of the machinations of the system. So when I say to you, public policy is a branch of medicine, I'm telling you that public policy is a branch of medicine, and that Center for Public Policy that we do is medicine. It's the way in which the logistical system is built to provide access. And Gretchen and I, you know, we've been in these wars so long, at so many fights, and I don't go into a fight unless I call up and say, okay, Gretchen, what are we doing now? How are we going to deal with this one? She's been fabulous. And I'm going to say this last word before I invite her up. The thing that she taught me the most is, let's go look at the statute. Let's go look at the policy. Let's go look at what's in writing. Don't let anybody tell you anything verbally. Go back and look at what does the law say, what does the policy say, who had the authority to do that. And the minute you get into that level of understanding of the system, you know the switches, you know where people are overstepping, you know where you can begin to maneuver. And that's the work that we do at NMQF. We go into the bowels of the system, trying to understand how those decisions were made that impact the life of the communities that we're working in. And Gretchen Wortman and her team are responsible for that. So Gretchen, big time, thank you, and please come. Thank you so much.
All right, everyone. Thank you all so much. We are here today to really acknowledge the challenges that remain for minority communities, but really to celebrate the progress that pioneers in this room have made. So give it another round for the awardees. Just one announcement before we wrap up. If you are attending tonight's gala, please find your name by the screens and locate where you are seated. The screens are over there. And we will see you all at the session right after this, and then at the gala this evening. Did I leave anything out? Yeah, all right. So thank you all so much, and session at 2 and gala this evening. So thank you all so much. All right, thanks.
We're like centered, yeah. Okay. making me look prettier? Okay, cool. Like I'm not really talking? Oh my gosh.
Okay, I had wherever you want to sit. Yeah, I mean, are you the cue? I am the moderator. So I'm speaking from here on the podium. Oh, okay.
Hi, I'm Alonzo Mourning, and I want to share an important message with you about APOL1 mediated kidney disease, or AMKD. AMKD is a serious, rapidly progressing form of genetic kidney disease that affects people of African ancestry. Those with AMKD are more likely to need dialysis or a kidney transplant sooner than those with other types of kidney diseases. So it's crucial to detect it early. Visit powerforwardtogether.com to learn more.
Thank you. Hello, everyone. My name is Moses Boyd. I am a lawyer and lobbyist, and I'm the advocate for the National Minority Quality Forums Action Network before Congress. Welcome to our final panel here today. We're going to be talking about the issue of healthcare costs. Some say it's the price is right. We have a very expert panel to speak to the issue of healthcare costs from several perspectives, from industry, from advocates, and those who have been in the space for quite some time. I'm going to let each of them introduce him and herself, and then talk about what you do, your companies, gives a brief, and then we're going to get into a discussion about the issue. But I want to set the table before we start to make sure we understand what we mean when we say healthcare cost. Sometimes people understand that in the most narrow and limited way, where they only focus on how much a drug is. But cost is also my health. So cost is when I'm not in a clinical trial, I can't be serviced. Cost is when I can't get to a hospital because it closed down, right? That's the cost to your health. And so when we speak of cost, what we're really talking about is still, how do we get people the health care that they need? Not just give them a help and give them a check and cut the Medicaid and say you give them something. And so when we speak to this issue of healthcare cost, we'll have a discussion today from that perspective. So I'm going to start off with you, Bill, and then we'll go in sequence. Yeah.
Thanks, Moses, and thank you, everyone, to joining us this afternoon. Very expert. I take note of that. I don't know if I agree with it, but I take note of it. So great to meet everyone. My name is Bill Raines. I'm here on behalf of Dexcom. We're the leader in glucose sensing technology. Many of you all who might be familiar with Dexcom are familiar with us through what's called a CGM, or continuous glucose monitor. That's technology found on the back of your arm that monitors your glucose levels, traditionally found to help people with type 1 diabetes. What we've seen over the last 6 to 8 months, even a year, is this technology blossom beyond just helping empower individuals with diabetes make their own healthcare decisions to far beyond that. And so prior to the development of this technology, if you were trying to manage your diabetes, generally you're potentially pricking your finger a couple times a day, trying to get a sense of what the what your glucose levels are doing based off of the food you're ingesting or the activity that you're performing. And then this technology has come along, and now you're allowed to access that through your phone and see it every 15 minutes, how your body is reacting. And for individuals with diabetes, that's critical because it means they can adjust insulin delivery, they can adjust their food intake, they can increase their activity or change their activity. And so it's been life-changing for individuals with diabetes and beyond. And I know we're going to talk about some of the policies a little later on that are going to impact the accessibility of this incredible technology. So just thank you again for having me today.
Thanks so much. Please go ahead, David.
Yeah, thank you, Moses. It's a real privilege to be here. I know the organization well, and so we're thankful to be a part of this. My name is David Burt. I'm the executive director of a new coalition here in DC that we're calling the Patient Access to Community Treatment Coalition. We really believe in sort of the value of local independent specialty practices. And so along with our organizations, we're out there advocating for a variety of policies to preserve and expand access to this important setting of care. Over the past sort of 15, 20 years, we're obviously seeing significant trends in terms of consolidation, a lot of pressures being put on independent practice. And we've seen sort of in oncology, in cardiology, and across other specialties for a variety of factors, whether that's declining reimbursement, increasing sort of practice expense, operations, workforce issues, as well as the rise in sort of other large players in the healthcare system. We're seeing a declining access of both providers and their practices and patient access in those areas. And so we're out advocating for a variety of policies that talk about sort of the benefit that is brought in that community setting. There's one specifically relating to an IR issue on Part B, which I'll get into in a second. I think it's one that's risen in importance for a lot of our community providers as well as the patients that we represent. Our coalition is a broad one. We started and had a lot on the sort of representing those specialty areas as well as those practices in oncology, urology, rheumatology, ophthalmology, and other specialty areas. I think equally important is our work that we're doing with the patient groups. They obviously have a very big vested interest in sort of talking about these access issues that are happening in the community. We partner with our industry friends as well, both from the biopharmaceutical world as well as in the distributor community, talking about how we get those innovations over to patients and do that. I guess just one final thing that I sort of want to talk a little bit more broadly on advocacy. We have clearly sophisticated groups that we're working with who are very effective in terms of what they're doing, but often we see a lack of coordination and sort of strategic advocacy across the different settings and the different groups. One of the things that we're trying to bring together is, often we have a policy outcome that we're looking to achieve, but the understanding of that issue, the policy solution, the prioritization, the different tactics, the policies involved, and the politics involved don't allow for that coordinated effort. And I think within our coalition, we're very well set up in order to bring some of that structure to this advocacy game. The last thing I'll say, which I think is critically important when we're talking about advocacy, is how do we bring together sort of the national game with the local game. Advocacy used to be, you could come to DC, if you were well connected, you could stomp the halls of Congress and you would deliver national statistics on national issues, partnering with national groups in order to get something accomplished. The world is not the same anymore. We see a lot of partisan division, both between the parties as well as within the parties. People have access to information everywhere. That brings new players into the scene. And so one of the things at PAC that we're very proud of is we work in DC with the specialty societies. We're set up to do that lobbying. But also what we have is we have a network of tens of thousands of individual prescribers, individual patients that we can then get to those folks in different districts, talk about what it means to their community, to their patients. We can put sort of op-eds, not in the Wall Street Journal, but we can put it in the North County Gazette and have that local advocacy that gives people a reason why they can sort of break with their party or break with other things in order to move these important advocacy issues. So we'll get into the policy in a little bit more, but I'll pass it to John.
Good afternoon, everyone. My name is John Hughes. I work for Merck. Merck is a 130-year-old company based here in the US, and we're a very science-driven company that tries to invest heavily in research and development and see where the science leads us, and hopefully come out with novel treatments and therapies after that investment. I have worked at Merck for 20 years, which when I say, I almost faint, like, oh my God, 20 years. But nevertheless, I've had a number of different roles at Merck, including several years in our commercial organization where I worked in HIV and oncology. And now I'm based here in Washington, DC, where I lead our oncology policy at the federal level. So cost is an issue that obviously is very important to us. It's something that we think a lot about, not just in terms of the actual product or unit cost, the cost to patients who may be receiving some of our therapies, but as Moses teed up, there's many different facets of cost, considerations of costs, of other direct and indirect costs that might be experienced for patients accessing our treatments. So hope to talk a little bit more about that as we go through the discussion, but I'm very honored to be here. This is an incredible organization. Thank you so much for including me.
Bethany.
Hi, everybody. My name is Bethany Lilly, and I'm the Executive Director of Policy and Research at Blood Cancer United. You may know us better as the Leukemia and Lymphoma Society. We changed our name about a year ago, and I will just say I'm still adjusting, so I may end up having to put some money in the swear jar today if I forget and say LLS. As at LLS, or at Blood Cancer United, our mission is to cure blood cancers and to improve quality of life for patients and their families. And I know that there have been a lot of sessions on caregiving and on other pieces at this conference that fit very directly into our agenda, and I'm delighted to be here to talk about another big piece of our agenda, which is cost of care. We have had a cost of care initiative at LLS since 2007. It's a big priority of ours because we have some of the most expensive patients. I have to admit we haven't updated these numbers in about a decade, but the last time we had them done, a patient with multiple myeloma was paying about $215,000 in their first year of treatment for services. Now, the patient's part of that cost would not be that high, but that means that for the healthcare system as a whole, our patients are in fact costing a lot of money. And if we extrapolate that with healthcare inflation over the past 10 years, we're looking at huge numbers. And that is pretty universal across blood cancers. Some are a little more affordable, some are not. Leukemia in particular can be very expensive. One of my aunts just passed away from AML, and I will say, like, her end-of-life treatment costs were considerably higher than I think anyone in the family was anticipating. So this is a real-life problem that we have seen in all of our patients, and that's why we started our initiative. We've been looking across the healthcare system. We've been looking at providers. We've been looking at insurers. We've been looking at where the incentives are set up so that patients are on the hook for money, and also looking at where is the system creating incentives that are driving up costs. And I know consolidation was mentioned earlier, and I know we have a few other topics that we're going to get into, but this is really something that, you know, we here at Blood Cancer United care a lot about.
Thank you, Bethany. And I'm going to start the questioning off here by asking each of you, what are the outcomes? What's the effect on the patients, the markets that you serve, when you don't succeed in what you do, meaning you're advocating for the cost of care? What happens to those people when they don't get the care? And John, I'm going to ask you the same thing. You guys, your company, Merck, makes drugs that help people get healthy and live longer. What happens when you have the data? What happens to people who have those ailments and they can't get the treatment? Same thing with you, Bill, on your device. And David, I'm going to ask you, with respect to the communities you advocate for, you talked about the parochial and the national. Well, you've been on the ground, you've seen those people. What happens when you don't succeed, when we don't extend the healthcare market there? So I'm gonna start with you, Bethany, to talk about it from a real human perspective.
Well, I think you set it up really well, Moses, when you started off with sometimes people just leave drugs at the counter. If you cannot afford, if you do not have a credit card with a high enough limit, you may very well leave those drugs at the counter. We were seeing that across our network and across our diseases. I will say, I think another place you see it is in medical debt. We, over the past 2 years, we're almost there. We started it in August 2 years ago, or like a year and 10 months ago, we opened up a medical debt case management program. And so far, we've helped just under 4,000 people, and we have helped them resolve $8.2 million in medical debt. And that is people who had extra bills. 95% of these patients had health insurance, but they are still ending up in medical debt because they cannot afford the care that they need to treat their cancer. I think that's a pretty straightforward answer.
Absolutely. Joe.
Yeah, that I would echo, we're very concerned by what I would broadly characterize as financial toxicity that was just very eloquently described. There are other dimensions as well that are deeply concerning to us and appear to be growing, and that's what some are beginning to call kind of time toxicity. So if you think about, there may be coverage for a drug, an individual may have access to it through their insurance benefit design, and yet there might be a prior authorization or other steps of utilization management that patients may have to jump through, and their providers as well, before they get access. So for instance, prior authorization, that's where a plan may want to kind of scrutinize, is this what's being prescribed medically necessary? And in some instances, it can be a quick decision. In other instances, it can take several business days, potentially a week, potentially 2 weeks. When we're thinking about it in the context of the work that I do in cancer, timing is everything, right? These are typically progressive diseases, and so that time added before a patient may be allowed to get on therapy, in some instances before they might be able to have a diagnostic to see if they're even appropriate for therapy. Those instances where time is added creates a great deal of strain, of undue burden. It can provide a lot of extra hoops that providers must have to jump through, whether it's through chasing down peer-to-peer engagements, other ways to try to resolve prior authorization. So that's something that, increasingly here in DC, there's a lot of discussion around prior authorization steps voluntarily, certainly in Medicare Advantage, where certain payers are saying, hey, we will commit to certain timelines to try to resolve some of those issues. One thing that perhaps isn't getting talked about as much, but we're deeply concerned about, is the growing use of step edits. So step therapy or step edits, sometimes in the context of cancer, can be thought of as a fail-first policy, whereby a patient and a provider, they may have a decision, come to a joint decision as to what the care plan should be. A prescription is written, and the plan says, oh, no, you can't start with that drug. First, you have to start on another drug, and if you fail that drug, then you can access to the drug that you and your provider decided upon. In cancer, let's be blunt. Oftentimes, many of these patients, their best opportunity for a long-lasting response is that first chance, particularly in metastatic disease. So fail-first policies are deeply concerning to us. What we've seen in the data over the last few years, going back to, it was only in 2019 that in Part B, in Medicare Advantage Part B, so think about physician-administered drugs in Medicare Advantage, it was only going back to 2019 where step therapy was allowed. But since then, we've started to see kind of a slow uptick in the number of plans, the number of covered lives that are subject to step edits. It was roughly 20% of covered lives in MA, in Medicare Advantage in 2022. It's now up to 60%. So kind of below the radar, while there's a lot of focus on prior authorizations, rightly so, we're also deeply concerned about that rise in fail-first policies, where oftentimes there may be very little medical justification for the decisions that some of these plans are making. So that's another element of cost that is something we're watching and advocating for.
Good point. Yep. Yes.
Yeah, thank you, Moses. And I think going back to sort of when we think about our coalition as we're talking about this, it's more aligned to what you were talking about in terms of cost to patient, in terms of experience, access to high quality care, than it is on price. And so one of the things that we're dealing with is how do we create a reimbursement system where providers are adequately reimbursed in order to be able to give the medicines that patients so justly and duly need? And then what are the downstream effects if they can't? And so we're dealing with a pretty acute issue with the IRA and the drug price negotiation. Our members, supportive of the reduction in costs, want to see that, but they want to see people have access to those therapies. And if we're living in a world where we are implementing these cost reductions through reimbursement reductions to physicians, then it makes it very financially challenging for them to give access to these products. And that's what our patients are going to be facing. Once you have a situation where the provider can no longer give it, then you bring in sort of time and travel issues for our patients. This means that in order to gain access to their therapies, they may have to be referred out. In worst case scenario, some of these providers are going to be closing their doors. So then there's distance issues that they have. These are immunocompromised patients that we're now forcing to travel across New York City or in rural areas hundreds of miles to go get a therapy. They're immunocompromised. They have to then go into hospitals where their chances of getting sick and other things are much greater. The burden isn't just on them. It's on their caregivers. It's on, in different communities, places where we have to take time off work. We have to pay for transportation. We have kids in childcare. All those different issues make it very challenging when patients really just want to receive their treatment from their trusted physician in those sites of care where they feel comfortable getting that treatment. I think the other piece that we're hearing loud and clearly from our patient group side of this is the idea of adherence. So there is statistical evidence that the further away a patient has to travel in order to get that care, the more likely they are to skip a treatment or go without. That may be less common in oncology, but in places like lupus and rheumatology and eye disease and others, people will skip those treatments. And we all know just what a catastrophe that is for outcomes down the road. And so not so much on just the price stuff, it's really an access on quality, on cost, but also really on that important patient experience piece of it that's so important to people going through these devastating conditions.
Appreciate the question, Moses. I think for us, access is not some nondescript word. Continuity of care is so critical for individuals who are using a CGM. I mean, it's in the word, continuous glucose monitoring. It empowers individuals to make their own healthcare decisions and keeps them out of crisis. When you have a lapse in care, when you have inaccessibility issues, what that leads to is an increase in hospitalization, increased comorbidities, and then a lower quality of life. Mm-hmm. And so that access to, from our perspective, CGMs, that continuity of care is so important. And so when we look at some of the policies coming out of here in DC or at the state level, that's one of the things that we've really been emphasizing with our legislators and policymakers to make sure that they're thinking about that continuity of care in all communities. I mean, it's critical. We have one of this unique products in that it lowers, bends the overall cost curve. It keeps people out of the hospital. It helps improve the quality of life. It lowers comorbidities. Mm-hmm. The second part is that it helps providers and physicians, gives them access to more substantive and tangible healthcare information for the people that they're treating. We're not talking step counts. We're talking glucose levels. We're talking individual characteristics of your own body, and that empowers physicians to help better treat you. And then lastly, and most importantly, we're talking about an improvement of quality of life. People lead better lives when they're on CGMs, particularly individuals with diabetes. And so when you have that, what I'd call a triple win, it's so important that we have that continuity care and that accessibility to this technology.
And each of you, in my opinion, has made the point of the consequence of people not getting the health care that they need. And that's, again, looking at healthcare cost from a universalistic standpoint in telling all of its elements. I'm going to ask the industry representatives a couple questions, and I'm going to ask the public organizational representatives a couple of questions. I'll start with you, David and Bethany. Given the relevance of healthcare to everyone, and it's a cost across regions, whether you're urban, rural, suburban, middle class, lower class, upper class, healthcare is a cost if you're not in the top 0.5%. So given that, and given that everybody can die and everybody can get sick, why is it not there a greater public mass movement for better healthcare?
I think that there is. I have been working very closely and our whole team at the Office of Public Policy have been working very closely with every single one of our members who pays for Affordable Care Act coverage through the marketplaces. Because you may or may not know, but the tax credits that made that coverage really affordable expired at the end of the year. And premiums went up an absolute fortune. And many of our members who have blood cancer cannot afford to continue to pay for those premiums without the tax credits. I know that Kristen, who lives in Maine and has spoken to Senator Collins repeatedly on this subject, her premiums were going up almost 4 times as much as they had been. And so those type of costs, she is making herself loud and clear, and I think many people across this country are making themselves heard loud and clear. I also anticipate that when certain changes to Medicaid start taking effect over the next several years, you are going to hear very loud and clear from a lot of people who rely very heavily on Medicaid, which I will say covers almost half of the children in this country and many children who have blood cancer. Those are going to be very heartbreaking stories, and I can guarantee you those folks are going to want to talk to their members of Congress about why they made these choices. I certainly do. So I think there is that movement. I think that it is a very large system and it's very hard to adjust quickly. Right. I think we'll actually see that with some of the Medicaid changes. I think it's going to be a lot harder to make these changes than states are anticipating. And so I think the implications that has for real people are very serious. And I'm very concerned about what we're going to see and whether or not people are going to be able to continue to access coverage.
Good points, and I agree with you. I slightly differ when you describe it as a movement. I would describe it as a sentiment and public opinion that's not been harnessed. But a movement is action because they did cut Medicaid, Medicare, Obamacare, notwithstanding the polls. So an active movement would have put enough pressure on Congress not to do that. So sentimentally, you're correct.
I would say that I think public opinion and public pressure was very clear, and I will be curious to see what exit polls following the midterms look like.
Okay. David, I'm just writing your belly.
Yeah, sort of challenging to follow. I think, it's very challenging to see, I think, and maybe jaded from being here in Washington for so long, but it does seem like so much that just the larger politics just always gets caught in the way. We right now, again, are advocating for an issue where we have folks across different specialty providers, across all patient groups, industry and others, all aligned on something. To my knowledge, we have no stakeholder opposition to a bill that we're pushing that would provide access to patients. And yet all I find myself talking about is, can we open up the IRA or not, right? I have members of Congress on both sides who, when they hear from local constituents, they talk about their local oncology or their local rheumatology center or patient who want to be there and supportive, but this sort of overarching fear of a committee or leadership or other things. And I think it just points to the need of this, like, it's sort of a movement. And I understand on Medicaid and other places there was that movement, and it was a uphill battle. But how do we exercise these voices? How do we force these members to listen to what's happening locally for them? And then, quite frankly, have them pay the price if they're not sort of supporting or doing what's right for their constituencies. And so, healthcare right now has turned into a thing where everyone has their piece of the pie. Everybody wants their cut of $1, and it's just become so complex in the world we live in that it seems like we've forgotten about the basic tenets of, how do we look after patients? How do we give them cost-effective care? And how do we think about their experience while we're doing it?
Okay.
Maybe, Moses, I'll add, I feel like yesterday we had such great speakers and leaders in the Honorable Congresswoman Kelly, Congresswoman Sewell from Alabama. I feel like we as industry, but also the patient groups, need to do a better job at empowering those leaders to push back. And I understand the pushback to that will be, well, what power do do those individuals really have? And I think we need to do a better job at making sure that we articulate, back to your point, Moses, the overall cost curve and what does that look like, and not thinking about these specific price touch points and helping articulate, hey, here's how the services that we're providing, here's how the services that we're seeking bend the overall cost curve and help people in the long run. And I think we as, across the board need to do a better job at empowering our champions like Congresswoman Sewell and Kelly and others.
Yep, I agree with that. And very good discussion here. So Bill and Jen, I'm going to ask you this question. It concerns what seems to be an ongoing issue, which is the failure of the market to reach all communities and all markets, right? And we have those market divides where the market does not extend into some of these marginalized communities, including a lot of Black and Latino communities. Dr. Puck referred to earlier in the session before this about some person with a company that it was a drug company suggested that they couldn't serve that community because Black people couldn't afford their drug. So I would say if you ever run into anyone like that in your company, you should fire them because they're an idiot. You're talking about a community that spends $2 trillion a year in the American economy. If you can't find a way to make money off that, then you should be fired. With that being said, how do you all, you have data, how do you look at how you extend your products to all these markets?
Well, we would fire that person. But I would just note that fundamental to what we try to do is address unmet needs. So we look where the unmet needs, and we will continue, if we believe that there's a scientific hypothesis that we can follow that may result in a novel treatment, we're going to do it. I'll share with you an example that's been very professionally important to my life, but also personally important to my life. So I work in cancer. Merck has a product called Keytruda. It's an immunotherapy. It has over 40 approved FDA indications. Now, in 2013, I started working on that product when we didn't have a name, we didn't know what it was going to become, and it was really just an idea that we had, that we knew that this was something cool, and we had to see how far it could go. 10 years later, going on to the end of where that product might be losing exclusivity in the coming years, we still don't know scientifically how far it will go. And so throughout the last decade plus, we've invested literally tens of billions of dollars in clinical trials to see what this product can do, where the science can lead to us. One example that's deeply personal to me is I have a family member who was diagnosed 3 years ago with triple-negative breast cancer. Now, many of you in this room may know triple-negative breast cancer, perhaps the most aggressive form of breast cancer, and disproportionately impacts women of color. We had 2 failed trials in triple-negative breast cancer with this drug Keytruda before we finally had a third that worked. Now, we could have said, okay, we gave it a shot. We could have pulled back. But we had a hunch that it would work. We just had to figure out in the right context and in the right point to intervene in that patient's cancer journey. And I'm very grateful to say that today, my family member, she's 3 years plus in remission. And knock on wood, all that stuff. So thank you. And that's for her, not for me, please. But I think it just goes to show that there are hard diseases out there. There are hard issues that haven't been tackled yet. We believe it's our job to make well-informed bets. Literally, tens of billions of dollars of R&D, as I said, year after year, to try to see if we can go and meet that unmet need. So we don't always get it right, but we really are committed to that. And so I think that that's an example where we still have ongoing studies in triple-negative breast cancer. We believe that there may be other ways to address it in combination. When we think about cancer writ large, we've made incredible progress, whether it's in triple-negative breast cancer, whether it's in melanoma, lung cancer, right? The rates of disease, of death due to those once almost incurable cancers have come down significantly. But we still have, I think by latest estimates, 625,000 people die in the US every year of cancer. 1,700 people die every day of cancer. Everyone in this room, I'm sure, has been impacted by cancer, whether directly or through a loved one. So we still have a long way to go. And the challenge is we just have to keep pushing forward. And in some cases, that means making trade-offs in, for instance, what we might have to say is a reasonable return that we have to provide to our shareholders, a reasonable return that we have to provide to continue to justify that level of R&D spend, and how we can then try to mitigate or work as best we can to make sure that we're making sure that there's still access in the patients who need these drugs the most.
Maybe I'll just follow up on a point, John, you made about clinical trials and the importance of that. Having appropriate representation in clinical trials is so key in achieving long-term impacts of whether it be a device or drug, better understanding the cost implications to the healthcare system, better understanding the patient impacts that ultimately, in your case, that drug is going to have. For us, a device, that starts up front at the making sure that there's appropriate clinical trials. And so I did want to highlight that, because I think that's another area where we as industry are constantly trying to evolve and make improvements in that space. But there's such a key aspect of that when it comes to the patient community, and making sure that they're pushing on individuals who are going through with these clinical trials, and making sure that there's an appropriate representation there. I think that has such a critical impact downstream that that's where it starts, right up front.
Go ahead.
I'm just going to try, as I'm sort of learning, dealing with more of the provider organizations, I think many of, and I've heard them talk about it now, like these networks of the local oncologists, rheumatologists, like they believe in this as well, right? They're in Harlem, they're in the Rio Grande, like they're looking for those patients. They're also running all sorts of support services, whether it's related to transportation or others, to enroll these patients, participate in how they can in the clinical piece of drug development. But again, they're working with finite resources on these things. And in an environment where your expenses are going like this, your reimbursement's going like that, it becomes very challenging for these guys to continue to do sort of all the good work and maintain a viable practice.
Good point. I want to follow up with both you, Bill, and John on that issue of clinical trials. Speaking objectively, not even from the perspective of your companies, what is the greatest impediment to diversifying clinical trials? Is it folks determining that market is not there? Is it the infrastructure is not there? If we had better clinical trial infrastructure, because obviously if you're diversifying your clinical trials, you're making a drug for a new market. And then we're going to have to come behind with David and Bethany and you, and how we mobilize the communities to get behind it, to pull it all together, which is the kind of coalition that Dr. Parker is building. But I want to answer from that perspective, what's the greatest impediment?
Yeah, maybe I'll just, I don't know that I have an answer for our time here today, but I'll add a third factor is trust.
Okay.
Making sure that there's appropriate trust within particular communities and the individuals responsible for these clinical trials, and whether drug development, device development, that is, it's such a critical factor.
Right.
Because I think it goes back to appropriate representation. If we don't have appropriate representation, that's going to have negative downstream impacts. And how do you build appropriate representation? In my mind, trust is a key part of that. And I think that there's a better job that needs to be done on our side, across the board up here, at establishing that. Is that the magic sauce? I don't know. I don't know that we're going to solve that in these 60 minutes.
But that's a good point if we build that
important.
infrastructure, because you guys are losing money by not being there. Go ahead, Joe.
Yeah, I just echo, I think it starts first and foremost with building trust, rebuilding trust, right? There's a long history of appropriate skepticism around clinical trials when we're trying to reach many different communities. What we've found, and we've been looking at this intensely over the last few years, is where we may not have credibility, how can we work with others who might? How can we work with local organizations? How can we work with historically black colleges or medical schools? How can we do other things to try to have others talk about how important considering a clinical trial may be? It may not be right for everyone, but to at least be included in the discussion and to weigh whether or not it's appropriate, I think is central to what we're trying to accomplish there. There are other, considerations that complicate sometimes our ability to execute clinical trials. So it may be that individuals have difficulty traveling to a clinical trial site. So how can we find site selection that reflects the communities and the patient populations that we're trying to address that have a high unmet need? There may be other issues with respect to just simple reimbursement of travel expenses. How to think about how often an individual may need to lose work to participate in a clinical trial. As all of you know, it's not just an individual who goes through cancer, it's their caregivers, it's their families, the support, the individual support system, the friends who may need to, drive them there. They might not feel well enough to drive home after, an infusion, for instance. So it's not just one individual that you're ever considering, but it's their whole support team and their family and those essential caregivers. Are they taking off time at work? How do we think about making this as seamless an experience for them as well? Further, there can be issues with respect to when you think about a clinical trial design, right? You're often thinking about, well, what's the experimental drug that you might be considering? So, when you have an experimental drug, often that's provided for free. But the standard of care in the comparator arm, is that provided for free? Is that not provided for free? In some cases, when we think about oncology, the standard of care increasingly may not be an old, legacy chemotherapy that relatively doesn't cost as much. It may be a very high-cost targeted therapy, a very novel agent. So when you're thinking about those comparisons, those costs can really add up. So there's many different considerations with respect to what we as a company are able to cover and what we may not be able to cover. But also, how do we work with organizations so that some of those direct and indirect costs that individuals who we hope will participate in our trials, how do we see that they have the best opportunity of getting some of those costs covered where it's appropriate so that they can participate in the clinical trial?
All very good points, Bill and John. And so I'm going, Bethany?
John had a...
Well,
I'm sorry, John. I'm sorry.
I just want to make the point, we believe this is the ethical thing to do, but we also think we're going to make more money in the end of the, so I just want to say, if we have clinical trials where we appropriately reflect the patients who will need these drugs someday, if we can substantiate the value of our products in those patient populations, at the end of the day, we think that we'll be rewarded for that. So, we don't want to shy away from that. This is an important business decision for us as well.
I agree. Black people spend money faster than anybody. You bring your companies there, they'll buy the drug. Bethany, so I'm going to ask you and David from this perspective, listening to the perspectives of industry and how they look at this and addressing some of these challenges of market deficiencies that are all part of healthcare cost. But now, I'm moving from there, how do we mobilize enough grassroots power to change the policies that can affect those things? And I preface this with the proverb of Frederick Douglass: power concedes nothing without demand. It never has and it never will. So until the demand gets right, you'll be in the same spot. So why don't you go ahead?
I think I'll start by echoing that diverse clinical trials just give us better science. Absolutely no question about that, and that alone should be why we are doing this. I mean, obviously the profit motivation helps too, but and I'll say that you may get a longer answer from me than you were anticipating, because one of my favorite parts of my job is that I get to advise our education and services team on our equity and access grant program, where we give money to health services researchers who are looking at exactly these kind of problems. We did an entire literature review 3 years ago about what evidence there is around diverse accrual in clinical trials, and basically there are not evidence-based interventions that we can point to, that I can tell the FDA, hey, if you required this would actually change the paradigm. And so we decided to pay for that research. And we just finished this year's grant cycle reviews, and the proposal we're funding got the highest scores of any proposal that we have gotten so far, and I am really excited about it. But to kind of look at it from the different proposals that we've seen and what people are looking at, they're looking at navigation. So they're looking at having individual, usually oncology nurses, help people walk through that process. And we do that at Blood Cancer United with our clinical trial support team. They take an average of 28 different individual interactions with a patient to get them enrolled in a clinical trial. Those are 28 cracks in the road that somebody can fall through if they are not getting enrolled in the trial. So to my mind, yes, we don't have perfect evidence on navigation, but I think it's really clear that that can be a really effective intervention. We're also looking at decentralizing trials. So we talked about transportation a little bit earlier. If you live in Brooklyn and you need to get across the bridge into the city and to your oncology appointment, that's probably going to take you an hour driving or on public transit. If you can get your blood test for the clinical trial at the urgent care 2 blocks down from your office, that's going to be a lot easier. People are going to have a lot easier time staying in the clinical trial because there's first getting people in the front door and then also having people stay enrolled. And so I think that decentralization nut, we haven't quite cracked that yet, but we definitely think that there's a lot of opportunity there to get more people, make it a lot easier for people to get enrolled and stay enrolled in clinical trials. And then finally, and we saw a lot of proposals on this year, around AI screening. So another big problem is that, frankly, due to preconceived notions and racism, you don't always have the population that you want getting enrolled in the trial because they're not who people immediately think of. But if you can take some of the human factor out of that and have this AI analysis of the medical records, key up the people who, hey, this person is qualified, maybe you should talk to them about the clinical trial, you kind of take some of those preconceived notions from providers out of the equation, it can be helpful. And so I think there's a lot of research being done now. We're certainly not going to be the only people funding it, but looking at, okay, what AI interventions actually work? What kind of a screen pop-up and an analysis of the electronic health record is going to work here? And I don't know that we have the perfect solutions on that. As I said, there's a lot of research being done, but if we can get that across the finish line, I would really hope that we would get there. Finally, if anyone does have anyone going through blood cancer treatment right now, please refer them to our clinical trial support center because clinical trials really can be the front line of treatment and it can be, for many patients, the best option. So especially when it comes to blood cancer where we're still really developing a lot of new treatments.
So I think you and John and Bill have said something similar. The more salient and robust clinical trial infrastructure we have that builds that trust and that stability, the more we can expand these markets, diversify the trials, and bring down cost. Like that's all part of it, because it's all part of this cost discussion. So I'm in the discussion here. We're going to open up to the audience for a couple of questions with you, David. Getting back to the point, how do we mobilize around this? There's an election coming up. Will people vote for the health care? Everyone seems to agree, including industry, we're not supportive of Medicaid cuts and Medicare cuts and Obamacare. So you had a coalition of folks who, the industry said that's not good for the industry, it's not good for patients. So now how do we mobilize around that?
Yeah, just quickly before that, I think just to add to what we were talking about here, I thought Bethany gave a great answer on that. I do think the trust piece comes back to it again. I have to imagine that as a patient is going through a treatment and there's a clinical option or something that's there for them, that relationship with someone who's been in their community, that's worked with their family, that is connected to the primary care physicians in that district or other areas is going to lead that person to be able to participate. In terms of, sorry, your question was?
Mobilizing to build a public support so that we can get the policies that we need, that you're seeking.
I think sort of more broadly, again, like we're pretty specified now in sort of what we're talking about and the goals of our coalition, but I think like it's challenging to come in and always ask for something. I think more has to be done to unify and sort of tell that story, do education, a bigger effort in our case on the value of community care, why it's different than hospital care, why hospital care in some areas is appropriate, but why we want to preserve these local access points. I think giving people more and more tangible things that they can connect to before you come in and say, I need a fix on this that's going to cost that, or whatever else it is. I think we're very, in Washington, it's a pretty reactive game. I know it moves slowly, but it's always somebody asking for something. And the best we can do in sort of bringing people together, not just advocating for our own personal perspectives of our group, but listening to what others are saying, learning from them, learning from past experiences. I think we all, from the industry side, which I've been involved in, to the provider side, to others, I think it's just trying to come up with a more unified long-term game, again, where you provide people that tangible experience, that it means something for that member, and then you hold them accountable for that.
All good points, and it's been very good talk. I think we can now open up to questions from the audience. Does anyone have any questions for our panelists?
You hear me? Is this on?
Yes.
All right. I appreciate the comments and suggestions about diversifying clinical trials, and just wanted to call out a couple of concerns I've had related to that. One, I think AI can be a powerful tool, but I also think we have to be cautious about over-depending on it, because the people who build the algorithms often have bias. And so, for instance, there have been race corrections in who is put at highest priority for a kidney transplant, and based on if you're Black, lower on the list, even if all the symptoms are the same. And so we have to be cautious about using AI and make sure that we correct for any of those biases. And then one question I keep posing that I haven't found anyone who can answer this, so if you have an answer, I'd love to hear. I've asked pharmacists, I've asked physicians, I've asked researchers, but why do we usually not incorporate body diversity in clinical trials when, if you're a child, you're prescribed a certain dosage based on your age and weight. But then when you become an adult, whether you're my size or Shaquille O'Neal, you take the same dosage of Tylenol. And that doesn't really make a lot of sense. And you see things like Plan B doesn't work for women over a certain weight, but what if they were given a higher dosage? Could that work? And so why do we not account for body diversity when considering prescription practices? Or what could we do to move clinical trials to account for body diversity?
I'll turn it over to you all. I'm a hustling lawyer, not a doctor.
So I think it's a very insightful observation. From my limited experience in oncology, I think that there are instances where we actually do look at weight-based dosing, and that can be quite common, particularly where side effects increase by dose. I think the optimal solution, generally speaking, right, if you could kind of whiteboard everything out and design it perfectly, it would be a single dose, just because it's simple. And that there's opportunities that then might create with respect to efficiencies in manufacturing and distribution and patient education, provider education, and so forth. But there are instances where you can't get around it, and you really have to try to figure out, well, what's the right dose for the individual who's sitting in front of us with their BMI, with their performance status, with other considerations that they may have. And in particular in oncology, when you're trying to avoid an increase in perhaps side effects that may rule out continued treatment, we try to find what's the right weight-based dose response there. But it's not universal, and I think that we could do more. Sometimes writ large, the royal we as an industry may cut corners here and there with respect to really thinking about how best to serve every individual patient rather than kind of broad swaths of the population. But where there are specific considerations in a given disease, we will try to incorporate that as best we can.
And I can just add on the AI piece, 100% agree with you. That is entirely accurate, and bias in algorithms is a huge part of why we want to study these algorithms and see if they actually work. See if they actually are increasing accrual, see if they're increasing accrual across the board for all subpopulations or just for particular ones, and then make adjustments. And that it's really interesting because when we were first reviewing these proposals, we realized there has to be a computer scientist involved because there has to be somebody who can go edit the algorithm and actually modify it if it's doing something that is having a disproportionate impact on one population or another. So, dead on. That's a great comment.
Thank you. Is there any other question?
Yes, I have a question.
Yes.
Hi, so I'm curious to know more about, so part of the conversation around diversifying these clinical trials and some of the challenges and getting folks to be participating in them. And I'm curious to know the role of community engagement in those processes. Yesterday, we talked a little bit about like untrustworthiness in the public health industry and in medicine. And one of the things that we've found in the work that I do in Rhode Island, and I'm sure across the country, as an effective way to mitigate the lack of trustworthiness in the health and healthcare industries is by engaging community partners and using participatory approaches. I know in Rhode Island in our HEADS initiative, we've had some really tremendous success in engaging clinical partners to address diabetes management, asthma management, substance use disorder research. And we did that by connecting clinical and pharmaceutical partners with community-based and community-led initiatives who were trusted brokers and trusted messengers of that work. And that's been a really effective approach of getting participants to participate in these research studies. So I'm curious to know what role has those kinds of approaches played in your work, or if not, where are there opportunities to do that? And I will shamelessly put it on the table that if there is interest in having a footprint in Rhode Island, our community partners are looking for more clinical and research partners who are, going to join them in addressing this work. So I will shamelessly put that out there to, connect with me if you want to do some work in Rhode Island. But again, I'm curious to know, to what degree is our participatory community-led approaches embedded in your work?
I'll let you answer, David.
Yeah, I probably have to defer a little bit more to Bethany, given she's actually at one of the organizations, but I am hearing more and more, like a good example is we have the Lupus Foundation on our board, and the more and more I work with them and hear about those things, they are set up to do those things. Lupus is a disease that sort of 90% of it affects women. I think sort of 2 to 3 times more prevalent in minority communities, also have much worse outcomes in those communities. And so I think a large part of what they're focusing on and things that they're working with the Office of Minority Health and different things to get appropriation line items, other things, they are trying to do that sort of community mobilization, working with local people, then translating that over into sort of policy making and other things. I'm happy to follow up with more on sort of specifics on that. But sort of as I'm sort of getting into this, I think you are seeing a lot of these groups trying to do a lot of those types of activities.
I would just say thank you for your comment. You described the best practice that we aspire to do. So if we're not there in Rhode Island working with you yet, I will reach out to you and we'll try to make that happen. We are trying to do exactly that in communities all across the country because we believe that that's critical to appropriately enrolling our clinical trials. So thank you so much for that comment.
Okay. Thank you. Good for putting it on the table. That's right. Next question. If there are no more questions, I'm going to thank our panelists. If you like any final words or say what you want to send the audience off with, it'd be great. We have a few more minutes and then we'll wrap up.
I think I will leave it with a challenge to the audience because I think we do have a movement on healthcare in this country and making it better for everyone. And I would just ask that everyone in this audience, and I know you all will because you're here at this conference, will make it part of their plan for the rest of this year to make sure that what they want from their elected officials actually happened, and if not, to hold them accountable.
Excellent, excellent. Well, I think that's a great way to end. Let's give our panelists a round of applause. And we appreciate everyone being here, and thank you very much.